Good morning, my friends. We may be a few minutes behind the schedule, as you say, but never too late. You are in here. We all gathered here this beautiful morning on the sacred grounds of Guntur Medical College. Inch for inch, as you walk the grounds of this prestigious institution, every stone, every brick, every speck of the dust speaks nothing but intellectual acumen and medicine and discipline. So, my dear friends, sitting in this august auditorium, may I be permitted to share the following with you, says Dr. Nirmala Karnam, who walked every inch of this beautiful grounds. This is what she says to each and every one of you. I came from a farming family not too far from here and struggled the way some of you have been and are even now. My academic journey was strewn with thorns that taught me here more than medicine did. Several decades ago, I walked every inch you're walking on now in this sacred campus I call my home all my life. I always had a dream to work hard and be firm in my resolve since I was in elementary school. That's what Dr. Nirmala Karnam is speaking to you. It's not me who's speaking to you, but your senior is speaking to you. Any and all difficulties I had faced along the way were nothing compared to my dream, and that was my counselor, and I overcame and achieved that goal and dream in the end. To the last breath of my life, my dream was my philosophy of life. It was personal and it was etched into my DNA. At each obstacle I faced, my resolve got quadrupled and my journey to find the truth became crystal clear. Though my parents were from a farming family with only a bit of education, they gave me some punyam. No book or a classroom instruction could ever impart. My dream was flashing through me no matter where I was led to. I saw poverty and suffering all around me, though I was fully shielded from such. But the dream kept me in pace with such a challenge to do my best to alleviate and try to up my service. As I grew up, my dream became my faith, my love, and my hope. making my dream come to fruition. Though the journey was long, pathway was landmined, suffering around me, I could see all that was beyond endurance for many. I stood up for them, and many a time I felt their pain and shed silent tears, but in the end, it was a worthwhile cause and a discovery for each with whom I reacted and communed. I have much more to share with each of you now, but while your time and space is limited, my own is infinite, immeasurable, and blissful. You are very young and very inexperienced. Your world is digital and your future is controlled by artificial intelligence and many other advances in science and technology, and they may deliver that could be something beyond human imagination. But remember, one core part of you, that is, you, each one is unique. One unique DNA. No other DNA can come to your DNA. You have the future in your palm of your hand. You too have a dream like I had. You too have choices like I had. Your own journey was not too distant from mine. Your core of your being will tell you where to go, how to sojourn, and where the blissful destination is. In the face of eternity, this time frame given to us is insignificant. A moment slips by us will never, ever come by this way again. Use it wisely, use it fully, use it to discover yourself, and use it to be healthy, truly happy, and share it with those who need your shoulder and your purse as well. Here are a few words for you. This is what I want to leave with you this morning. Not every goal will be fully achieved. Not every job will end successfully. Not every relationship will endure. Not every hope will come to pass. Not every love will last. Not every endeavor will be completed. Not every dream will be realized. But when you fall short of your aim, perhaps you can say, yes, but look at what I have found along the way. Look at the wonderful things which have come to my life because I tried to do something. Oh, my family, my parents, my relatives, and my friends. You gave me all I ever wanted. I have gone far away physically, but not in spirit and in truth. I will surround you and embrace you as ever and protect you. I will do my silent advocacy with the divine, so all of you who have touched me will have peace, good health, great joy. So one day, you will be with the God who is dancing with me. So says Dr. Nirmala Karnam, and bids you so long, which means I, Dr. Nirmala Karnam, wherever I am, I will journey with you, I will stay with you, I will protect you, I'll keep you on the straight path. So long till we meet again. Thank you. This is the second year of Dr. Nirmala's series of memorial lectures or orations to be delivered in this great GMCANA auditorium. Dr. Nirmala Karnam will play a prominent role only to be as of service, as of love for each and every one of you. A foundation was registered in the United States in the name of Immaculata NA Foundation, Inc. of USA. Why Immaculata? Why NA was inserted into this title? N means Nirmala. In Sanskrit, Nir means no, Mala means stain, which translates into English, immaculate. A, because our sister, Nirmala's sister-in-law, who was Sister Amala, passed away 10 months before for a small accident. At the age of 64, she had rescued 5,000 poor children in Kadapa, Pulivendala, Ongole, wherever she was. And her name was Amala. A means no, Mala means stain. Both from different families came together, also immaculate, pure. So I chose the name N.A. representing both of them. Immaculata, immaculate in Latin, is translated into Immaculata. So you know, when you hear, when you see, when you watch what Immaculata is, NA is. So I just wanted to share with you so you won't get what is this Immaculata NA Foundation. And the objectives, very simply, the major objective is for each and every one of us here to take a bullet if a female is hurt anywhere in the world. That is the cause of this foundation, the education of the female, the safety of female, the empowerment of female, anything that represents a female that transforms the world, and anyone who dares to touch you uncharitably, this foundation empowers you to fight back. One strike, the adversary is done. So I would like you to know this is the foundation that has been created in the United States, and shortly it will be registered in the great state of Andhra Pradesh and throughout India to undertake the best we could do for the female students, for the females. That does not mean the male is neglected. The male will be empowered as well to make sure to see the divine value in the Vanitas of our world. With that, may I be permitted to welcome first our new principal, but not new to this campus, the great neurologist who just took over less than a week ago, Dr. N.V. Sundarachari, MD. May I have the privilege, honor, sir, for you to come and take the seat on this podium. Thank you, sir. Next, may I invite Professor Chennupati Jagdish, Distinguished Professor and Head of Semiconductor, Opto, Electronics and Nanotechnology Group, Australian National University President, Australian Academy of Science. If I continue longer, this may take forever. May I have you, sir, come and take the podium. And next in line, may I take this opportunity to invite the great Dr. Gulla Surya Prakash, MD, DM, MBA, Hospital Administration, FSCAI, FACC, USA, FESC, Europe, and an alumni of AIMS. Our chief speaker and orator of the lecture this morning is Dr. Gulla. Let's give him a hand. I'm not sure if our great members of the Legislative Assembly are here this morning. I guess they're always busy trying to serve our people. So, of the 4 guests of honor, we have a very, very special person with us. May I take this opportunity to invite Dr. Shobha Devi Nakana from UK, a diabetologist and obesity specialist, to come and be seated on this prestigious Madam, would you be kind to look at our wonderful faces? Stay, madam. They say, madam, they say in all languages, the beauty and the intellect never goes together. If it does, it would be very devastating. But she has the intellect of being a physician, a diabetologist and obesity specialist from UK. But something happened. In 2019, she was crowned Mrs. Telangana. That is not done yet. In the same year, she went and competed in Chennai for the crown of Mrs. India. You didn't hear the last word. She won it handily. That was not all of it. That was not all of it. In 2021, she was specially declared a beautiful person, Mrs. of Universe. Even though I would be humbly requesting Dr. Srikanth, MD, your cardiology chief, who pretty much saves each and every one of your life as long as he is on the campus besides teaching. May I request you, sir, please come to the stage and take your seat. Yes. Well, I wanted to make sure that I have invited the great people of this institution. And there are heads of the departments, there are professors, there are teachers, and there are your best of the best seated right in front. Then we have a great madam right here who is retired. May I have you, madam, kindly stand up. Dr. Rajalakshmi Garu, Rajeshwari Garu, sorry, doctor. Dr. Rajeshwari Garu, Professor of Microbiology. Let's give her a big standing ovation. So, may you be kindly seated. With that, the introductions are over because these are some of the greatest people you will ever meet on this podium. So, if I stop at this and not recognize your two pillars of this institution who hold with their bare hands, along with the principal, the two vice principals. Sir, may I have the privilege to humbly request you to be in front of the audience. The vice principals are Dr. B. Sridhar MD Garu, and the other vice principal, Dr. K. Prabhakar Rao Garu, Professor and HOD of Physiology, and Dr. Sridhar Garu is a Professor of Pathology, Vice Principal Academic. How honored we are today to have the principal, two vice principals right amidst us, letting Dr. Nirmala Yarra Karnam be eulogized and also honored. Thank you, both of you, the vice principals. While our chief guests are sitting on the stage, two of the vice principals were sitting right there. They are with you more than the chief guests are with you. Thank you. Well, I am supposed to be the MC. MC means Master of Ceremonies. My name is Raja Karnam. I am Dr. Nirmala Karnam's husband. I am not a physician, but throughout the world, wherever Dr. Nirmala and I went together, I was chosen always as the doctor, she was as the housewife. So I know a little bit of medicine, but humbly I would like to tell you, Dr. Nirmala always said, I am not the doctor, Raja is the real doctor. But I practice TV medicine, but you know what TV medicine is. But still, it is pretty effective. But I'm honored, I'm humbled to be here to conduct this particular program this morning. And I thank you for bearing with me, and I thank you for listening to what I'm sharing with you. Today, this program is presided by none other than one of the greatest neurologists that you have as your principal, Professor N.V. Sundarachari Garu, principal of your medical college. Professor N.V. Sundarachari Garu is a senior neurologist elected as a fellow of the American Academy of Neurology. A fellow of the American Academy of Neurology, which means is widely regarded as one of the world's most prestigious honors in the field of neurology and medicine. Dr. Sundarachari Garu has been elected for making valuable contributions in the field of neurology. డాక్టర్ గారు ఇక్కడికి వచ్చి తెలుగులో చెప్పాలంటే ఒక వారమైనా కానీ ఈ ప్రాంతాన్ని ఈ ఆవరణని వెలిగించేశారు ఆల్రెడీ. అంతకంటే నేను ఆయన గారిని చూడంగానే ఆఫీసులోకి వెళ్ళంగానే ఆయన నా హృదయంలో అతుక్కొని పోయారు. ఆయన గారు ఈ పొజిషన్ తీసుకున్న తర్వాత నేను ఆఫీస్లోకి వెళ్ళినప్పుడు చూసి, ఏంటి ఇంత యవ్వనంలో ఉన్నారేనా, ఏదో గడ్డాలు మీసాలు ఉంటాయి అనుకున్నాను. సో అబ్బాయిలు అమ్మాయిలు చూడండి, ఎంత ఎంత గొప్ప డాక్టర్ గారయ్యి ఎంత ప్రేమ, అనురాగము, ఆప్యాయత, అన్యోన్యత, అవినాభావ సంబంధాలని నాకు కలిపారో. నా తెలుగును మన్నించి, let me go back into my broken English, I guess, whatever it is. So may I invite the principal to come and give his wonderful introduction to us all. Thank you.
A very good morning to all. Respected guests on the dais, guests of the dais, my dear students and colleagues. I am extremely delighted to stand before you to give this first of its kind in my life, to address the gathering on the occasion of second memorial Oration-Lecture on the name of Dr. Nirmala Karnam. I was a student of this college. I have joined in the year 1981. I finished my MBBS from this college. I was born in the year 1964. Madam Nirmala was born in 1962. No, she joined in the first year MBBS in this college in 1962. When she joined in this college, I was not born. When I came to this position as principal of this college, I took charge on November 1st. See, I am speaking on behalf of her, a legendary personality, a divine personality. She is no more. That is the journey of life. My year of birth was 1964, and by that time, she was in third year MBBS. Why I say she is a divine personality, my definition of God is an adjective. It's not noun. I don't believe God in person. I believe God as a quality, a divine quality. Madam had all the qualities. Madam has love, sympathy, empathy, compassion. On her name, today we have gathered here to get some knowledge on the evolution of cardiology from conventional to interventional by an eminent speaker, Dr. Gulla, Surya Prakash garu, a famous cardiologist, a senior cardiologist, interventional cardiologist. When I was a student of MBBS, I had passion towards cardiology. Even now, whenever a student comes to me, I ask 3 questions. These 3 questions inspired me during my journey of 43 years from 1981. The first question, why the heart is little towards left? Nobody can answer. The answer is not found in the books. So, I came to know from my seniors, my professors, who were legendaries in cardiology. The reason for the heart to be on left side is the absence of medial basal segment in the left lung. Because of the lack of medial basal segment in the left lung, heart moves towards left. When the heart moves little towards left, right diaphragm gets elevated. This explanation you will not find in any book. So this explanation was given by my teacher. I inspired to become a cardiologist, but I could not. I have written. Another question, why the most common organism for brain abscess in tetralogy fallow, the most common organism is group B streptococcus, anaerobic streptococcus. But what is the reason? Because there is anaerobic metabolism. Because of cyanotic heart disease, the organisms flourish in anaerobic medium. So, such is the beauty of cardiology. Why the child with VSD, ASD is prone for recurrent chest infections? Everyone says the lungs are plethoric. No, that is not the reason. Because of the left to right shunt, the arteries are hypertrophied, and the arteries, because of muscular nature, they compress the veins. When there is a compression of the veins and bronchi, there will be stagnation of secretions. Whenever there is stagnation of secretions, it is prone for infections. So these three questions inspired me to become cardiologist, but I could not become. My Srikanth has become cardiologist. See, everyone is unique in this universe. The children born from same womb, same mother are not same. Sirs already told. Sri Karnam Raja Garu already told, everyone is unique. The children of same mother are unique because the unique DNA. At the same time, no one is superior, no one is inferior. Everyone is unique by himself. You are ocean by yourself. The thing is how you explore, how you transform. I was born from a rural background in a village in Palnadu district. My father was a farmer. I did not expect to become doctor. Not by choice, by chance I entered into these premises. My father did not attend to join me. My neighbor, Ramireddy Garu, has joined me. So this is how you can transform. See, when you are born, you are born crying. When you cry, your parents laugh, smile. They become cheerful. Your relatives become cheerful. You celebrate. But when you die, how many people cry for you? That should be the motive of life. Anyway, with this brief message, I thank the organizers, especially Raja Garu and all the guests on the dais, the faculty members of this college, students of this college, for giving me this wonderful opportunity. First opportunity after joining in this college as principal. Joined on November 1st. I am extremely delighted. I am very humble. I am extremely happy. Thank you so much for giving this opportunity.
May I have Professor Jagadish Garu to felicitate our wonderful principal. Let's give a big hand. A memento on behalf of Immaculata NA Foundation is being given to the principal. And thank you, Mr. Dr. Principal Garu, for giving your first message on this campus. We are very privileged. Immaculata Foundation is very, very grateful. And you see the humility, you see the core of a person, and you see the love, and you see the determination, the grit that he had to become one of the top neurologists anywhere that we can find. And his message is very deep, very moving, and extremely useful for you, first year, second year students, and the other students, and the nursing students. Remember the message. Messenger may not be here, message will transform you. Thank you, Dr. Principal Garu. Just for a change, for a minute, I'm going to request Father Brito, is the principal of Pulivendala College, to give us a song, a cappella, without music, without instruments. And it's a last minute request, and he's going to sing a song for all of you. Thank you, Father Brito.
Good morning, everybody over here. I request every one of you to close your eyes and feel with the song that I'm going to sing. It is a hymn related to Psalm 139 from the Old Testament. The lyrics are generic in nature. Everyone can relate to this, and you can feel the presence of God, the God whom you relate to each and every day. Prabhu needu prema nundi nenekkadiki pogalanu. Prabhu needu prema nundi nenekkadiki pogalanu. అపారమైనది నీ ప్రేమ, అనంతమైనది నీ ప్రేమ. అపారమైనది నీ ప్రేమ, అనంతమైనది నీ ప్రేమ. సత్యము నీవే, జీవము నీవే, జ్యోతియు నీవే ఓ దేవా. సత్యము నీవే, జీవము నీవే, జ్యోతియు నీవే ఓ దేవా. ప్రభు నీదు ప్రేమ నుండి నేనెక్కడికి పోగలను. గగనమునకు ఎక్కి పోయినను, అక్కడ కూడా నీ ఉందువు. గగనమునకు ఎక్కి పోయినను, అక్కడ కూడా నీ ఉందువు. పాతాళం క్రింద పరుండినను, అక్కడ కూడా నీ ఉందువు. పాతాళం క్రింద పరుండినను, అక్కడ కూడా నీ ఉందువు. అపారమైనది నీ ప్రేమ, అనంతమైనది నీ ప్రేమ. అపారమైనది నీ ప్రేమ, అనంతమైనది నీ ప్రేమ. సత్యము నీవే, జీవము నీవే, జ్యోతియు నీవే ఓ దేవా. సత్యము నీవే, జీవము నీవే, జ్యోతియు నీవే ఓ దేవా. ప్రభు నీదు ప్రేమ నుండి నేనెక్కడికి పోగలను. May the soul of Dr. Nirmala garu rest in peace. Thank you.
Thank you, Father Brito. Just a sentence. Today, Father Brito, Father Velangani, who is providing us a live link of the video that is being telecast around the world. Almost 200 nations will be watching. And Father Bala from Andhra Loyola College. All three of them are celebrating 10 years as Catholic priests. Let us give them a big applause. Now moving ahead, we're a little bit behind, but we will do the next part of our program. Our chief guest is well known in the world. Dr. Professor Channupati Jagdish Garu is a distinguished professor and head of the Semiconductor, Optoelectronics and Nanotechnology Group, Australian National University, ANU, from 2009 till today. President, Australian Academy of Sciences, 2022 till today. Visiting positions, University of Oxford, University of Tokyo, National Taiwan University, University of Hyderabad, IIT Delhi, IIT Hyderabad. I have his bio and resume that reads like a book. So, Dr. Jagdish Garu, I have no words further to introduce him other than you all know Bharat Ratna. Is there anybody who doesn't know what Bharat Ratna is? He has Bharat Ratna of Australia. Let's give him a big hand. The Order of Australia. The Order of Australia recognizes Australians who have demonstrated outstanding service or exceptional achievement. There are 4 levels of award. The Order of Australia has also a military division. Awards in this division are recommended to the Governor General of the Ministry of Defense. Anyone can nominate a member of the community for an award in the Order of Australia. Nominating someone is a chance to recognize a peer for their hard work, service, and dedication. It is an opportunity to celebrate those inspiring people who make Australia what Australia is. Companion of the Order of Australia is the award given to professor. Individuals are appointed a Companion of the Order of Australia, AC in the brackets, for eminent achievement and merit of the highest degree in service to Australia or to humanity at large. How fortunate each one of us is here to have someone of that highest caliber, cadre, intellect, and the nanotechnology, artificial intelligence that we are moving into. We are very privileged, honored to have Professor to deliver his chief guest's message this morning. Thank you. Let's give him a big ovation.
Thank you very much for Sri Raja Karnam for that kind introduction. Good morning to all of you. And Professor Sundarachari, Principal of the Guntur Medical College, and Dr. Shobha Nakkana, the world-renowned diabetologist, and Sri Raja Karnam and family, Dr. Rajeshwari, and Dr. Sridhar, Dr. Srikanth, and Dr. Prabhakar Rao, and medical faculty and fraternity, and students and ladies and gentlemen. You will be surprised to know that many of the people on this stage, they've all, as principal said, that he started his life in a small village in India. I started my life in a very small village in India, and not only that, I studied in front of a kerosene lamp till I finished my year 7. I lived with my maths teacher in a neighboring village in order to be able to finish my high school. Without my maths teacher's help, today probably I will be plowing the fields in India today. So everything is possible in life, and if you really believe in yourself, and you really, and also put the hard work needed to achieve, and that's what I would like to convey to the students today here. And believe in yourselves, and you're studying in a great college, and I would like to congratulate you and wish you well for your future. It's a pleasure and honor for me to be here today in Guntur, having studied in Guntur JKC College in Intermediate, and also to honor the Dr. Nirmala Karnam on the 2nd Memorial Anniversary Lecture. And really, I want to sincerely thank Sri Raja Karnam and Professor Kodandaramaya for inviting me to participate in today's function. And Dr. Nirmala Karnam is a highly distinguished physician and a psychiatrist with 10 American board memberships and 8 MDs, which is unprecedented, and she dedicated herself in the service of the people till her last days. I pay tribute to her and her dedication and commitment to the profession with small beginnings in a village near Ponnuru to highest leadership positions in USA is truly commendable, and she is a source of great inspiration for all, in particular younger generation and women physicians. Let us give a big hand and pay tribute to Dr. Nirmala Karnam. Everything is possible in life if one believes in themselves and put the hard work needed to achieve their goals in serving the profession, and Dr. Nirmala Karnam was a great example of this. Guntur Medical College has trained many eminent physicians, and they are in leadership positions all over the world, and Dr. Nirmala Karnam is a jewel of the GMC alumni, and her achievements are really commendable, and also GMC should be proud of having an alumni like Dr. Nirmala Karnam. And I also want to sincerely thank Dr. Sri Raja Karnam, and of course Dr. Nirmala used to call him also doctor, and we'll call him doctor as well, in her memory, for instituting this memorial lecture series in honor of his beloved wife and life partner for close to 50 years, Dr. Nirmala. Today's speaker, Dr. Gulla Surya Prakash, an eminent cardiologist from Care Hospitals in Hyderabad, is a great choice for today's lecture. Dr. Surya Prakash has dedicated himself to the profession and in serving people through his regular visits to Guntur and Bobili to treat people from lower socioeconomic parts of the society free of charge. And his dedication and commitment to serving people is highly admirable. I congratulate Dr. Surya Prakash being chosen for the second Dr. Nirmala Karnam Memorial Lecture at Guntur Medical College, the alma mater of Dr. Nirmala. Please join me in congratulating and Dr. Surya Prakash. Let me go away from medical science and let me talk about science itself. Science has an important role to play in the society, and policies based on evidence will allow democratic societies to flourish in the post-truth world of mis and disinformation. As many of you know, on social media, a lot of mis and disinformation is been spread around. So as youngsters, I want you to think about and then see, is it true? Or can I go and then look at the evidence for whatever the information which has been shared? So the science and the evidence is very important for the future of our societies. Otherwise, societies can collapse and democracy can collapse. So that's why science really has an important role to play. Societal challenges such as climate change, national security, health and well-being of people, food security, and digital transformation and pandemics need science more than ever, and policymakers need to take into consideration of science while making decisions which are impacting the society. Investments in research and development is essential if we want to address the societal problems and also enhance economic growth and really be able to improve the quality of life for people from the rural areas and remote areas. And so including for India, investment in R&D is absolutely critical if we want to really solve the problems of our society. And Australia, now I'm Indian by birth, but now I call myself as Australian, and people call me Indian Australian. I would like to see much stronger collaboration and cooperation between Australian science and technology sector and the Indian science and technology sector. Both are vibrant democracies, and there's a lot for us to work together to really address the global problems, because none of us have got solutions to the global problems like pandemics or the climate change or energy transition for zero carbon economy or so. So that's why only by working together we can achieve much more than we can do on our own. And science and technology also has an important role to play in the medical field. Interdisciplinary, multidisciplinary approaches are essential to provide quality care for patients, including personalized medicine. Developments in genomics, phenomics, proteomics, artificial intelligence, data science, nanotechnology, and quantum technology are already playing an important role in the medical field itself. My own field of nanotechnology is seen as a technology of the future, which is impacting all industry sectors, including agriculture, electronics, computing, communications, displays, energy, medicine, pharmaceuticals, renewable energy, and transportation, and the list goes on. So what is nanotechnology? If nanotechnology is playing such an important role, what is nanotechnology? Nanotechnology is engineering at the atomic and molecular scale. We know that we can take Lego blocks and we can make whatever the shape you want, but we are really, instead of using Lego blocks, we're engineering the atoms and the molecules in order to be able to make nanostructures so that they can really be of use for range of applications or so. And in medical field, nanotechnology is expected to have a major impact in the longer term. Nanotechnology is enabling early diagnosis and treatment. US National Academy of Health has introduced Nanotechnology Center for Cancer Research in order to be able to identify cancer at the early stages and be able to treat cancer as well, particularly the targeted drug delivery. Targeted drug delivery allows us to really be able to minimize the side effects and also reduce the cost of treatment for people as well. Quantum dots are being used in identifying the blockages in the heart arteries in place of dyes currently being used, so that you can also identify the early stages of any blockages so that the cardiologist can be able to identify and treat you before it becomes a major issue for you. Again, nanosensors. In fact, in my own laboratory, we have developed the breath sensors. If you want to learn about the diabetes or ketosis, instead of using the pinpricking and looking at the blood glucose content in the blood by essentially measuring the chemical components of the breath itself. We're able to really identify the level of diabetes and ketosis or so. We're in the process of commercialization of that particular technology. Like this, the list goes on. Now we are dealing with wearable sensors, which are really continuously monitoring our health. And again, that has a huge impact. In fact, again, they are based off of the nanotechnology as well. The artificial intelligence and data science is going to play an important role in terms of being able to identify that some of the things which have been missed by the physicians, because artificial intelligence is able to really look at these images and comparing them with the people with the actual problems. So thereby, that helps to be able to identify people, those who have been missed by the physicians. That also helps the physicians. Essentially, artificial intelligence will be assisting the physicians to be able to treat the patients much better than what we're able to do. In summary, science, technology, engineering, mathematics, and medicine are interlinked with each other and have an important role to play in addressing societal challenges. Multidisciplinary approaches are essential to achieve optimum outcomes for patients. Thanks again for this opportunity to participate in the Dr. Nirmala Karnam Memorial Second Anniversary Lecture Function. Dr. Nirmala's legacy lives through her work and this lecture series and the philanthropic work of Sri Raja Karnam. Thank you very much and enjoy the day.
May I request the presiding principal Garu to honor Professor Jagdish Garu at this point. And Professor has given us an insights into nanotechnology and also how it is useful in our day-to-day life, besides being in every aspect of our lives. His resources are extremely important for India as a nation, Andhra Pradesh as a state. And I do hope they will capitalize and explore and exploit the intellectual acumen of our professor from Australia. And he has given you an early insight into how particularly this campus, you as medical students and those who are in healthcare field must be fully aware how nanotechnology is being used and how artificial intelligence will play a big role as you graduate and move forward in your life. So let's give him a big standing ovation for our chief guest. Thank you. We will move, kindly be seated. We will move forward quickly. Here, Dr. Nirmala Karnam being the focus, let's have our special guest to honor her with petals. May I request each one of you to honor Dr. Nirmala Karnam with the petals that are provided over there. Thank you very much. May I also request all the guests of honor on the stage to do the lighting of the lamp, not only for Dr. Nirmala Karnam, but everyone, every family, every one of you, so that you move forward in the light of intelligence. The dignitaries will be lighting the lamp. Thank you.
कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम्
Now, for us to the most important part of our gathering together today, which is Dr. Nirmala Karnam and her memorial lecture oration by Dr. Gulla Surya Prakash Garu. His biography and his degrees and his achievements are beyond my expression. He has an MD, DM, MBA Hospital Administration, FSCAI, FACC USA, FESC Europe, and an alumni of AIMS of Delhi. Presently, he is working as senior consultant cardiologist at Care Hospitals, Hyderabad. He was born in Raupalli, a small village in Vijayanagaram district, and comes from a rural, lower, middle-class background where there are no educational facilities. Because of that, he had to walk to the nearby Mandal headquarters for his primary schooling. He has graduated MBBS degree from the Andhra Medical College, Visakhapatnam, Andhra Pradesh during 1984 and won gold medals in several subjects. Then he got a seat in MD General Medicine in the prestigious All India Institute of Medical Sciences, AIMS, New Delhi. And an MD degree was awarded in Hyderabad, and the DM Cardiology awarded in 1995. Also, he did an MBA, Hospital Administration, from none other than Nagarjuna University, Guntur, in 2018 and 2019. He received world's famous prestigious fellowships from the Society of Cardiovascular Angiography and Interventions, Washington, D.C., USA in 2012, and also the American College of Cardiology awarded him fellowship in 2014 for his dedicated work and contributions to the field of cardiology, which gave him international recognition. He also received fellowship of European Society Cardiology in February 2014 for his outstanding contributions to the field of cardiology. He has published 70 publications in various national, international journals and conference proceedings, and also attended numerous conferences, seminars, and workshops worldwide as a delegate, keynote speaker, chairperson, and he's a resource person for the past 29 years. Right from his student days, he has been working for poor, needy people and around his village areas. And I can go on and on and on. He is a doctor with a heart, though he is a cardiologist who takes care of the hearts. He is an epitome of compassion, love, dedication, loyalty, and the supreme part of him goes every month for the last 27 years. He comes every month at Vishwamji's ashram to conduct a free camp. Give him a standing ovation. I can go on and on and on, say things about Dr. Gulla. As I said, he has a heart. That is very important. While you listen to his cardiology and the evolution of cardiology, remember there is a heart behind the cardiology. And he does the same service in his native place in Bobli. Every month he goes and dedicates, and he helps, he cures, and he does his job. So today in our midst, a famous cardiologist who will be delivering the second annual lecture oration, which is very, very important because nobody is spared from the cardiac problems, the way life is going on. They said men are most prone to cardiac problems, but the research has proven that the women are equally at risk. So, without any more introduction, may I invite Dr. Gulla to deliver his lecture oration for Dr. Nirmala Karnam and for each and every one of you. Thank you.
Sir, with your permission, I have a feeling, sir. We all pray Almighty to rest the soul of Dr. Nirmala to be in peace. But my prayer is she should be born again to serve society. To reform society, to treat society. She should be born again and again. Thank you so much. Another point is, I have seen Ambedkar having 50 degrees. After Ambedkar, I have seen her having 20 or tens of degrees. It's my feeling, madam. See, I've become emotional. Today's lecture imparts knowledge to students, imparts wisdom to cardiologists and colleagues, and it also inspires people like me to go for oration on my father's name. Thank you so much.
Lights, sir. Lights. Good morning to all who are gathered here. The respected chief guest, Professor Jagdish Garu, and the principal of Guntur Medical College, and other dignitaries and colleagues and faculty of this medical college, and mainly students, the future force for Indian medicine. So here, whatever I think Professor Raja Karanga told, will be nothing. Out of affection and love, he told many things. Of course, every one of us should take responsibility and do something for the society before thinking what society gave us. So here, the initial few words about Mrs. Nirmala Garu. She is a great doctor, philanthropist, and morely human being with humanity and the service mind. I'm very grateful to have this opportunity, especially in this medical college, the second memorial oration. I got the chance because my dream was wanted to enter Guntur Medical College during my medical course. Unfortunately, I couldn't get the opportunity, but seeing the growth of the people who are eminent physicians, surgeons from Guntur Medical College, mostly going abroad. From Visakhapatnam, we never had that type of history initially, only from Guntur. So I was wondering, so many people, including my classmates, transferred here for internship and gone to abroad and settled with a good career. So now I got the opportunity and chance to enter into the medical college and auditorium and giving this oration on behalf of late Dr. Nirmala Garu. And I'm thankful to Professor Raja Garu, who is the husband and a good human being of Dr. Nirmala, and continuously he was on the job, and he already committed in his introduction that series of lectures will be taken care on her memorial lecture in this auditorium. And I think our chief guest mentioned briefly about her achievements and everything. I think this is mostly for younger generation who should get inspired of some people like Dr. Nirmala, who is a legend in her field and acquired 10 fellowships and 8 MD degrees from USA. It was never happened in the past in the world to any physician. So I don't know, and people should analyze and then see and get inspired and take the path of Dr. Nirmala. So her, as it was mentioned already, born in a small village with the middle class or low class family, and struggled and worked hard to get into all these achievements. So these are the professional career. So 10 important qualifications. Out of 10, 8 are MD degrees in the mainly psychiatry and neuropsychiatry and service to disablement. Disabled people, she took MD degree for just serving disabled people only. So she, till last minute, she struggled and worked for needy people and served many people with honesty and straightforwardness, the big heart. So I think we all, especially the younger generation, should keep her career in mind and then inspire and do something to the society as she did. Now we'll go to the main, the oration, and here I would like to, I was given an hour time, but the topic I choose is the cardiology evolution. There is no end for it, still evaluating, and the younger generation should take care of the next generations who should achieve more than what was achieved so far. There is a special interest in this, not only me, I think my generation, including our great principal, great neurologist, will accept, agree, because during our medical school, when joined throughout MBBS, I have seen some of the things. Mostly I heard many things, but never seen, never did it. So after MBBS, when I got into a prestigious institute, All Indian Institute of Medical Science in post-graduation, what are all I missed in MBBS, I saw and I got involved, I did the work for the patient care. Similarly, later on the post-graduation, then super specialty, when I started DM, what are all I missed in the previous years, I could see and I could do with my hands. So the cardiology definitely gone into a vast development and revolutionized many of the things for the last half century. Though it was started in 100 years ago, initially, it was just first 50 years, not much. The second 50 years till now, vast majority of development in the science, technology, and drug developments. So that is the reason why I chosen this topic, and I would like to mention here, I'm very fortunate to be joined in medical field during 1978. So just 1977 only the majority of the cardiology developments took place, including the ultrasound of the heart, that is echocardiography, who got Nobel Prize, and the other is ultrasound, which later on percolated into the cardiac diagnostic evaluation. And the major interventional cardiology started with invention of percutaneous balloon angioplasty in 1977 by Gruentzig, who is in fact, unfortunately, he died at early age, but he is the father or grandfather. So this is the landmarks of development in cardiology. The first, if you see the ECG machine occupying a room size, this is the only, that time, M-mode echocardiography, Einthoven, who got later the Nobel Prize. And similarly, the lot of cardiology developments and cardiology people, scientists who, majority of them won Nobel Prizes during their research. And the second major aspect is drug developments. The majority of the scientists developed important drugs, including like beta blockers and ACE inhibitors. All these people won Nobel Prizes for their first inventions. And I mentioned about Grundtvig, first angioplasty in human being, he did in 1977. Later on, enormous development of intervention cardiology, which I like and I'm practicing right now. The major nowadays, today's talk is in the world cardiology population is TAVR, transcutaneous aortic valve implantation or aortic replacements. Without surgery, the transcutaneous replacements of the valves, not only aortic valve. This is the person, gentleman, Dr. Alain Cribier from France, who is the pioneer and developed and did first transcutaneous aortic valve replacement in 2002. Fortunately, I had an opportunity to work with him in France, in his university, with for coronary interventions, and watching his research attitude of valve developments. So with this development, cardiology itself is a subspecialty. And in cardiology, there are many subspecialties, like the clinical cardiology is a foundation, it can't be forgotten. That is the major pillar for development of all these, what we and patients need. Then cardiac imaging, the intervention cardiology, and cardiac electrophysiology, and pediatric cardiology, and most importantly, which I like, is a preventive cardiology. I think preventive cardiology, in the later slides, I'll emphasize on this, how Professor Jagadish field, that is nanotechnology, artificial intelligence, how it helps in preventive cardiology aspects. And heart failure is a major end-stage heart. And cardiac transplantation and the vascular medicine. So these are the Nobel Prize winners in the field of cardiology who did the vast development and revolutionized the total cardiology practice in all types of cardiologists, non-invasive and invasive. So in this, the mostly like ultrasound, like first is electrocardiogram, the other next is ultrasound of heart, that is echocardiography. Next, some of the drugs like including beta blockers and the cholesterol lowering agents, especially the LDL receptors. All these led to winning Nobel Prize to the great scientists. This is a humble beginning. This is a 17th century William Harvey, who started working out on circulation. Like he invented mostly like all circulation, what we are learning, what we learned is William Harvey. And this is the phase in 20th century where these three inventions, the X-ray by Röntgen, and the first I mentioned ECG by Einthoven, and sphygmomanometer, these three led to the vast development of clinical medicine, especially the clinical cardiology. If you go back 100 years ago, 1924, Osler, he recommended a quiet, regulated, orderly life free from excitement. That means like avoiding stress, sorrowness is the main, and some dietary modification, basic things for coronary artery disease or acute myocardial infarction. He also recommended that patients with serious heart diseases not to be informed of this, but that should act as a friend or relative to the patient who is suffering with severe heart ailment. The only cardiac surgery was stripping of the pericardium was available in 1924 with patients constrictive pericarditis. And later on, if you see the present, the total burden of all over the world, coronary artery disease, atherosclerotic cardiovascular disease consisted of only weight reduction and the blood pressure control and salt intake. These three were the mainstay of treatment in 1924, 100 years ago. There was no specific treatment for acute heart attack, which is almost a dead-end heart disease. Without treatment, most of the people would die first 24 hours only. The only just bed rest, liquid diet and general supportive measures. So later on, I was telling about half century was just silent. The next half century, now what we are seeing, and especially in my career, seen all these things and involved in doing all these procedures today. The echocardiography and imaging modalities have evolutionary diagnosis during last 4 decades. The rapid advances in drug manufacture, I was telling about important drugs like beta blockers, ACE inhibitors, and ARBs, and ARNI, angiotensin receptor inhibitors. The invasive cardiology paved the way of interventions. Today, I think everybody knows and heard about the rapid development of interventions, and no patient should die of coronary artery disease today unless is staying in a remote area. Later on, the plain balloon angioplasty in 1977, which led to, in these 4 decades, the CHIP, that is complex and high risk interventions developed, and now any type of atherosclerotic coronary artery disease can be tackled by this CHIP tools and intervention technology. So this is the almost like earlier we used to depend on cardiovascular surgeons. Now with this CHIP, the majority of the interventions were done, even surgical diseases came down, and surgeons having really a tough time to, but still we respect surgeons because some of the subsets we can't treat. The surgeons has to get involved. And later on, the structural heart diseases on the rise. In the last 2 decades, I was telling about TAVR, transcutaneous wall replacements are going up. And next is the implantable cardiac defibrillators for life-saving procedures as for ventricular fibrillation, ventricular tachyarrhythmias. And the heart failure subset requires CRTs. This is cardiac resynchronization therapy. It is a type of device which helps in treating heart failure and prolonging life and giving a good quality of life. And the other important life-threatening problems, after getting heart attack, after getting angina, after getting circulatory problem, people will die of majority with cardiac arrhythmias, tachycardias, all sorts of tachycardias like atrial, ventricular. And for them, we have option, and the almost last 3 decades, now the radiofrequency ablation and cryo pulse field ablation, controlled direct current shocks. So the future is still there. Please, youngsters, investigational cardiology, then now presently the interventional cardiology. So, with this gross outline, I'm going to just briefly give each heading. This is clinical cardiology. This will never go. Don't get the impression that technology takes care of clinical cardiology. Clinical cardiology is the foundation and pillar. Then cardiac imaging, the intervention cardiology, the management of cardiac arrhythmias, and a few words about future of cardiology, which is very bright, and I'm going to discuss few slides. This is now clinical cardiology. This is basically the foundation. Without clinical cardiology, we won't have any developments. We don't have any thought processes for developing the rest of the cardiology. He is a gentleman, the father or grandfather of cardiology, Professor Eugene Braunwald. I think some of the few people knowing. Of course, he died at the age of 95. And fortunately, I got opportunity to work with him and in landmark trials. So, a lot of inspiration from him. So, I just tried to practice as he taught. The major case study here is a cardiac drug development. For cardiac drug development, we need to understand pathophysiology of disease, which required and led to drug developments. Developments pharmacology is basically the enormous drugs in the cardiovascular treatments. The most important thing is the clinical trials. Clinical trials, a word, I think vice principal is here, the principal, I think he must have gone urgent. Then the medical colleges, especially in the districts or presently the world medical colleges, still lag behind the clinical trials. So I request people who takes care of this administration, I think encourage students for clinical trials. So they beacon of light for entire field of medicine. Unless we have trial and document evidence base, we can't even go further, we can't even blindly treat like a RMPs. So landmark clinical trials are many which revolutionized the cardiology practice today. The transformational change, these trials transform patient management and outcomes. And not only the treatment and natural history of disease is known with the clinical trials and helps in preventive cardiology. The various classes of drugs now we have in the cardiology, the mostly commonly the antihypertensives, not only for cardiologists, the physicians, the lipid control medication, antiplatelets and anticoagulants, and today the NOACs, this is non-oral anticoagulant drugs. The neurohormonal modification for heart failure is the highlight of the development in cardiac management. ACE inhibitors and angiotensin receptor blockers, beta blockers, MRAs, mineralocorticoid receptor antagonists, especially the spironolactone, and now presently ARNIs, the angiotensin receptor and neprisilin inhibitor, which is a new drug and totally changed the treatment of heart failure, and this drug is presently lost almost of heart failure patients. So the hypertension, as we all, is the most important component of invasive blood pressure, invasive blood pressure monitoring, and lot of devices are coming now with, this is for continuous monitoring and evaluation of the patient's hypertension over a period of 48 hours or 72 hours, how with. So the evidence base here, the 1940s, the very basic drugs, ganglion block alkaloids with a lot of side effects, and later on led to the many important drugs like diuretics and centrally acting drugs, clonidine, calcium channel blockers, and 80s hypertension, and completely avoids drugs. Into all these drugs can be tackled, total cure of who entered hospital with hypertension uncontrolled. The initially earlier days used to be question whether we should treat diastolic hypertension or not. And earlier guidelines also were not in favor of treatment, even if diastolic blood pressure was 100. So later on, that question was answered, and lot of clinical trials and natural history studies showed the enormous complications with even diastolic hypertension above 85 millimeters of mercury. So along with systolic hypertension was answered. And these are the guidelines, basically the world famous guidelines, JNC, Joint National Committee for Hypertension, diagnosis guidelines. Initially, there is no specific recommendation for treatment of hypertension, which led to many complications. So later on, each information and drugs. So depends upon the associated comorbid conditions, the guidelines describes or suggests drugs, which drug to be given to which patient with which comorbid condition. So, and here a word, guidelines are guidelines. We can't follow totally 100%, we can't totally give them 100% respect, because each patient is different and each physician is different. With experience, we should modify our own regional guidelines, and that the only people should encourage in the medical colleges. Students get into innovative ideas and form a local guidelines. The next important aspect of the disease burden is coronary artery disease. All over the world, it kills many people. And the classic studies, the Framingham heart study, the earlier, half decade back, this study identifies the risk factors. Risk factors, I think all of you are aware, including like smoking, cholesterol, hypertension, diabetes, and stress, all these things. Identifying and then try to modify those risk factors with the available resources that time, and which paved the way of prevention. Then later on, introduction of coronary care units, that is intensive care units, which really helped a lot in making comfortable for acute coronary syndrome patients like unstable angina or acute myocardial infarction. And later on, development of thrombolytic agents in 1970s, major stride in myocardial infarction management. So here, the same thing I was mentioning about my life perspective is I had it during my MBBS 1978, 18, 81, 84. Then I could never see any thrombolytic agent, streptokinase, basic component. And when I went to All India Institute of Medical Sciences in MD, throughout my period, I enjoyed using the latest medication. So today, what you are listening, the developed things, maybe you people will use and you may invent new things. Please concentrate on research and developments. So drugs, I just already mentioned about ACE inhibitors and beta blockers, how they modified, changed the total scenario of acute myocardial infarction and complications. Then potent antiplatelet agents. These are all pathophysiology related, pathophysiology based developments, the lot of thrombus, ongoing thrombus, and which lead to myocardial infarction. So the potent antiplatelets agents took a major role in treating and controlling and preventing events. The next is like interventions, angioplasty, the later on primary angioplasty. For acute myocardial infarction, we never had that we should do angioplasty as a very high risk and table deaths, all those things. But still, we could dare, and it is implemented in 1980s and 1990s all over the world, practiced as a regular basis for acute myocardial infarction, saving lives. And similarly, parallelly, we know the surgery, cardiac surgery, how important it is. And we have legends in surgery. And fortunately, I got opportunity to work with the world famous surgeon like Denton Cooley. And similarly, in India, I don't know how many people will remember and take out their names. From this college, Dr. Prasad Rao, the Padma Shri, who was a pioneer in many own technology improved. He was with us almost 25 years in Nizams and care hospitals. Still he is active and doing surgeries. Still I remember 1991 when we were in Nizams, the patients coming now after bypass surgery done by Prasad Rao, till today with good grafts, maybe some venous grafts troubling, but 30 years later also we see the results. I have not seen any good surgeons other than Dr. Prasad Rao, is a Guntur Medical College product, and he is there. I think I sent the link to him. He is in US today with his children. Maybe he is watching. So the surgical things, though the majority of the surgical diseases are taken care by intervention cardiologists, still they have a major role in especially the aortic dissections and all those things which can't be tackled total, and the complex anatomies, pediatric complex cardiac diseases will be dealt by surgeons. These landmarks in coronary disease management, I think already I was mentioning the series of developments in management of coronary disease. The pathophysiology, coronary thrombosis was identified in 1912. See how great people, the cause was identified, but unfortunately it took half decade, more than half decade, 1912 to 1976, more than half decade, to develop a drug for treating the cause. So streptokinase was the initial thrombolytic agent. Now today we are using latest recombinant technology, tinecteplase, which melts the clot in front of our eyes. If we see in cath lab, if we give intracoronary tinecteplase, that is called TPA, it gives, just melts away. So the perfusion starts. Similarly, the intervention started angioplasty and later on stenting. So the mortality decline, I was telling people used to die the moment they get heart attack. So here, more than 400 deaths in 1 lakh population in the initial 1950s. Thank God we born all, I think born after 1960s only. So we have opportunity to get utilized if someone of us gets. So 1977, the angioplasty, 1983 surgeries, and 90s, after 90s, the major intervention cardiology took place along with different types of stents, bare metal, and later on drug-eluting stents, which reduced the mortality. If you see the figure here, less than 100, the four-fold reduction in mortality with the development of cardiac science. So these are the drugs, various groups of drugs and treatment for the important two components of coronary artery disease is ST segment elevation myocardial infarction, standard one. The non-ST elevation, this is called non-STEMI. So the various drugs like simple aspirin, people wonder if they didn't read, the undergraduates especially, simple aspirin given on the onset of chest pain with acute myocardial infarction reduces 23% of mortality. Unimaginable. I didn't believe when I started reading, then I saw simple aspirin. With combination of other drugs, you can imagine how much percentage of benefit to a patient with acute myocardial infarction who is dying. So this same like drugs, of late we got very good antiplatelet agents like clopidogrel and ticagrelor. This is the latest antiplatelet we used. It prevents a lot of stent thrombosis, etc. When stents came, we used to get afraid stent thrombosis in 24 hours, in 72 hours. So now there is no incidence of stent thrombosis, I can say. Maybe 0.001 operator problem, not the drug problem. Those are wonderful drugs. So in summary of this CAD, so as I mentioned, more than 400 deaths in 1 lakh population in 1950s, and now after 2000, less than 200. Now today, with all available technology in latest interventional cardiology, with all like including intravascular lithotripsy, with imaging guided procedures, we can reduce even less than, we are seeing less than 100. So the next important drugs, the lipid lowering drugs. There are a lot of rumors and wrong notions with WhatsApp spread, the media, wrong media spread. The lipids, recently the FDA also said something like only company driven, unnecessarily people are taking statins, all those things. Kindly listen here. There is nothing mentioned here without evidence base. So lot of trials showed these are the wonder drugs in 21st century. So statins, sorry. Statins in 21st century, we can call them wonders. Statins along with beta blockers, ACE inhibitors, antiplatelets and ARNIs are the pillars of contemporary cardiac management. Other classes of recent additions, ezetimibe, fenofibrate, and latest is a bempedoic acid, which controls LDL cholesterol, those who are not responding to the original drugs. The other latest development is PCSK9 inhibitors. This is a protein casein inhibitors. These drugs, like once in 2 weeks, we can give, and these creates lot of benefit in intracoronary thrombus clearance. The other one, now today, the last maybe 1 month, we got into India, this inclisiran. It was available in Europe and America, but now we are already started using the gene silencing drug that works by turning off the PCSK19 gene, which is the culprit for deposition of thrombus material with LDL particles. So this is now recommended every 6 months, of course costly, $1 lakh per injection. Every 6 months people have to take, high risk people, not everybody required. High risk means repeated episodes of heart attacks, recurrent episodes of symptoms, despite procedures. So this is, I was telling about evidence-based medicine. the lot of trials, secondary prevention and primary prevention study like Jupiter, which showed undoubted benefit for reducing cardiac events and by controlling LDL cholesterol. In fact, all these trials, majority of the trials showed the control of LDL up to 70 or less than 70 should be advocated, and see that the target is 70. In the interventional trials, we see after complex angioplasty stents, we recommend with the evidence base less than 50 LDL cholesterol. So it may be a surprise to many of the aggressiveness should be there to control cardiac events. American College of Cardiology and of late Lipid Association of India, we all combinedly recommended the lowest LDL should be less than 50 for having maximum benefit. The next entity is heart failure. A simple word, but this is basically end stage, final pathway of all heart diseases irrespective of the etiology. To get all these heart failure subset, of course, directly or indirectly, we are the culprits. Why? Because we are treating all patients initially, we are controlling their cardiac problems and giving good quality of life till they reach this stage, heart failure. So at the end, definitely all these people who are benefited maximally will end up with heart failure. So the science and society is ready to tackle all these things. The initial studies showed very poor outcome once they get into this stage, heart failure stage. The rapid advances in drug and device development changed the outcome. I believe the two concepts that changed the outlook radically are, the one is a neurohumoral antagonism with ACE inhibitors, beta blockers, and MRAs, these mineralocorticoid receptor antagonists, and now ARNIs, I was mentioned about ARNI. And the cardiac resynchronization therapy, that is a device therapy where dysynchrony was found in majority of the heart failure patients. Then this resynchronization therapy helps in controlling heart failure, prolonging life and giving a good quality of life. Then later on, this advances in LVADs, left ventricular assist devices, and transplant. These two entities made a lot of revolution in sick patients who are not responding to the above measures, and the lot of work being done and lot of utility is now seen. This is last 3 decades, what happened to heart failure means the same repeating, like consensus trial of like ACE inhibitors, then like routine drugs, diuretics and vasodilators initially. The later on 1996, heart failure, 20%, 27% reduction in the hospitalization and cardiovascular causes, the use of beta blocker, that is a carvedilol. Then the other is rail study, mineralocorticoids, receptor antagonists, and the later on, the most important thing is here, ARNIs, drugs, angiotensin receptor inhibitors and neprisilin inhibitor. This is most recent developed modality for heart failure treatment. And surprisingly, a diabetic drug, SGLT2 inhibitors, we know the dapagliflozin and empagliflozin, which not only controls diabetes, they helps in heart failure with reduced ejection fraction subgroup and heart failure with preserved ejection fraction also. Ejection fraction, that is pumping function of the heart. So the fundamental therapies, and now we see the developments. And this is the, I think, for heart failure, the final study for final slide. The 4 pillars of heart failure. The one is ARNI, the second is beta blocker, the MRA antagonist, and SGLT2 inhibitor. These 4 completely changed the outcome of heart failure patients. And the additional therapy, resistant population will be required, the devices. I was mentioning about CRTD, cardiac resynchronization therapy with a defibrillator, which helps in controlling heart failure. The advanced heart failure, I mentioned about LVADs, that is left ventricular assist device, and transplant. Lot of work is done and well established. And he is a gentleman, Denton Cooley. I think most of the people must have heard it. The same, I was fortunate to be with, especially for fellowship in cardiac transplantation in Texas. I spent some time with him and learned many things. So people wait for the opportunity to work with people like legends and try, don't leave. Unless you try, you don't get opportunity. Oh, okay. So we'll this is a slide, the same thing, like how improved the outcomes. So the youngsters here, the small break, inspire. Many people are here. Many people are here. You see many people in the slides. And try to develop yourself and learn more and do more and find more and give it to society.
We will continue the lecture oration in a few minutes. We have in the midst of us a very, very important person. Mrs. Madhavilata Gulla garu, our Guntur 2 member of the Legislative Assembly, is right here sitting. Let's give her a big welcome. May I invite our beloved MLA Garu to come on to the stage. Please stay for a minute. It is not over. It is not over. The lecture is not over. Let's give a standing ovation for Madhavilata Garu. మాధవీలత గారు మీరు చూస్తూనే ఉన్నారు కదా, ఆవిడ విగ్రహం చిన్నదే కానీ కీర్తి చాలా గొప్పది. ఇప్పుడు she represents directly the entire institution in the Andhra Pradesh Legislative Assembly. She is very powerful to be your advocate. This institution comes right in the middle of her governance. Anything happens here, you can go to her. I went to her hospital, I went to her office, straight away I could walk. So you have the same privilege. So without much more introduction, she has a bachelor's and master's degree. She also manages a hospital here. She's an MD, so she knows quite a bit about medicine, hospital management, and what goes on. So may I request our MLA to come on and give her message to all of you. And also, Dr. Madam is going to honor our beloved MLA. Madam Madhavilata Garu will give 2 minutes message for each and every one of you. Please kindly stay and listen to. It's very, very important because what she has to say makes quite a bit of your future. Madam.
Thank you, sir. So, andarki namaskaram andi. It's really a great honor stepping onto this stage today in this premises. Endukante Guntur Medical College antene it's a prestige. World wide ga ikkadi nunchi doctors unnaru. This is the pride of our country. Aithe ivalla ikkadiki vachi mee andartho few words ni share chesukodam nijanga chaala happy ga undi. And being a part of this memorial event also oka pakkan chala baadaga undi because we lost somebody. And at the same moment వారిని గుర్తు చేసుకునే ఈ ఒక మూమెంట్ ప్రయత్నం నిజంగా చాలా హ్యాపీగా ఉంది. కర్ణం గారికి నిజంగా a great applause అండి. ప్లీజ్ a big applause I request. ఎందుకంటే సొసైటీకి చాలా డెడికేటెడ్గా వర్క్ చేసిన వాళ్ళు ఆ పార్ట్ అయితే వాళ్ళని ప్రొజెక్ట్ చేసేవాళ్ళు చాలా ఇంపార్టెంట్. ఈరోజు ఎవరి వర్క్ వాళ్ళు డెడికేటెడ్గా చేసుకుంటూ వెళ్ళిపోతూ ఉంటారు. బట్ వాళ్ళకు ఒక గుర్తింపునిచ్చి వాళ్ళని సొసైటీకి పరిచయం చేసి వాళ్ళని ఇన్స్పైరింగ్గా తయారు చేసేది మాత్రం పీపుల్ లైక్ హిమ్. సో వీ రియలీ అడ్మైర్ యూ సార్ ఫర్ దిస్. అండ్ నిర్మలా గారి గురించి చెప్పుకుంటే ఈరోజు ఓన్లీ టుడే ఐ కేమ్ టు నో అబౌట్ హర్. 8 MD డిగ్రీస్తో ఆవిడ ఈరోజు తన లైఫ్ స్పాన్ మొత్తం కూడా ఈ యొక్క ఫీల్డ్కి డెడికేట్ చేశారు. అంటే ఇట్ ఆల్ షోస్ హర్ డిటర్మినేషన్ అండ్ డెడికేషన్ టువర్డ్స్ ద ఫీల్డ్ విచ్ ఈజ్ రియలీ ఇన్స్పిరేషన్. మనందరికీ కూడా అది మన మనసులో ఉండాలి. మీరందరూ ఒక ఆస్పిరేషన్తో విత్ ఆల్ డెడికేషన్ సీట్ సంపాదించి ఈరోజు ఇక్కడ ఉన్నారు. సో దీన్ని త్రూ అవుట్ యువర్ లైఫ్ ఈ మూమెంటంని ఇలాగే పెట్టుకుని you need to achieve your great endeavors in your life. I really all the best everyone here and making me part of such a beautiful event. I'm really thankful to all the organizers and Surya Prakash garu even and madam of diabetology, and I'm thankful for everyone. And okate oka suggestion andi, people like Nirmala garu life nunchi manam నేర్చుకోవాల్సింది ఒకటి. If at all ఒక పాయింట్ని మనం పట్టుకుంటే త్రూ అవుట్ ఆ లైఫ్ దానికి డెడికేట్ అయి ఉండాలి. డిటర్మినేషన్ అండ్ డెడికేషన్ ఆర్ ద ఓన్లీ కీ ఫ్యాక్టర్స్ ఫర్ ఆర్ సక్సెస్. అదొక్కటి మాత్రమే మనకి మిగతా అన్నీ కూడా ఎలా కావాలి, ఎలా సంపాదించాలి, ఎలా ఓవర్కమ్ చేయాలి ఇవన్నీ నేర్పిస్తాయి. ద ఓన్లీ అన్కాంప్రమైజింగ్ డిజైర్ అదేదైతే ఉందో, మన బర్నింగ్ స్పిరిట్ ఏదైతే ఉందో అది మనం మనసులో పెట్టుకోవాలి. ఈరోజు ఒక డిగ్రీ ఫినిష్ చేసేటప్పటికి మెడికల్ ఫీల్డ్లో ఎస్పెషల్లీ పీపుల్ ఆర్ లూజింగ్ దేర్ ఇంట్రెస్ట్. ఎందుకు వచ్చానరా నాయన ఈ మెడికల్ ఫీల్డ్కి, ఈ MBBS ఏంటి, PG ఏంటి అండ్ సూపర్ స్పెషాలిటీ ఏంటి, ఇట్స్ ఆల్ ఏ లైక్ హెడ్ఏక్ లాగా అయిపోయింది. ఐ నో, అంటే గ్రోయింగ్ కాంపిటీషన్ ఇన్ ద ఫీల్డ్ ఆల్సో ఇట్ ఈస్ డ్రాగింగ్ పీపుల్ ఇన్యాక్టివ్ యాక్చువల్లీ. ఇన్ దిస్ సినారియో, ఇలాంటి మూమెంట్లో ఇలాంటి వ్యక్తులని మనం చూడడం, తెలుసుకోవడం వల్ల నిజంగా మన లైఫ్ ఇట్ టేక్స్ అ టర్న్ యాక్చువల్లీ. సో ఐ రిక్వెస్ట్ ఎవ్రీబడి, ఒక బుక్ రాశారు అద్భుతంగా, ఆ బుక్ని మీరు అందరూ కూడా జస్ట్ ఒక 5 to 10 minutes ఒక డేలో స్పేర్ చేసి చదవాల్సిందిగా నేను కోరుకుంటున్నాను. ట్రూలీ ఇన్స్పైరింగ్. And for all the MBBS students here, I think all empty chairs I am seeing, maybe I am really late and I don't take your much time. Thank you very much who are here. Peddavallu unnaru and honors unnaru. I really thankful making me part of this event. Thank you.
Thank you, madam. Ati chinna vayasulone you can see we have an MLA representing a very powerful constituency, Guntur 2. She represents the future of politics. We need young people like her to get into the politics, not to be powerful, but to be the servant of the people. It is her first time she is in the party as well as a representative of our people. You go to her office and you see what is happening. She is there meeting everyone. So we need more and more of Mrs. Madhavilatas to represent us, to take us to a new generation, take us up into the skies in our lives. Thank you, madam. And she has spoken so well, both in Telugu and in English. So we need to be prepared to work hard like the madam did. It's not easy in politics to suddenly become a representative. No matter what party you belong to, it requires dedication, great determination, hard work, and love. That's what Mrs. Madhavilata, our representative, is. Please give her a great clap. And remember, go to her if you need. I have seen it for myself. Thank you, madam, for coming. I invited 3 different members of the Legislative Assembly and see who came. The person who came with love is the MLA of Guntur 2. Thank you, madam. Now, may I request Dr. Gulla to continue his lecture oration. Thank you for being patient.
I will continue. A few more entities left. We'll finish fast. The heart failure management, we already, it's like basically the classification of types of heart failures and the modality of treatments. The next is important entity is cardiac imaging, from diagnosis to interventional cardiology. So the imaging started with initially echocardiography. The initial introductory slides I was mentioning about echo, how it developed and revolutionized the cardiac anatomy and management decisions. 1940 to 2020, the enormous developments, including like mode, 2-dimensional, contrast echography, cardiography, Doppler and tissue Doppler, and 3-dimensional echocardiography, which almost shows the total anatomy externally. And the recent is real-time 3D echocardiography and speckle tracking is the ongoing research which helps further. We don't require any invasive investigations for congenital heart diseases, which directly the surgeon can take into OT. The first echocardiography machine developed this is like basically occupying a room, but only M mode function we used to get. So this M mode of only valves, nothing else. So later on, which led to developing more sophisticated, started with mechanical transducers and then the piezoelectric transducers, which are more sophisticated and acquires lot of information from the cardiac chambers across the valves, flows, etc. And this is a Doppler echo, which really encouraged people to get more information and helping in further managing medically or intervention or surgical. So this is mainly the valvular heart disease function and non-invasive hemodynamic assessment, like pressures in the heart chambers, pressures across the valves can be measured. And most importantly, the congenital heart diseases, which are basically with ECG and X-ray only limited information in congenital heart disease, especially the children. So the Doppler made lot of difference. Then the interventional echocardiography, how it helps is the first rash kind did balloon atrial septostomy in a child, dying child with congenital cyanotic complex heart disease, creating a septum, hole in the septum by guiding echocardiography, saved the child, and this came into vogue. And tissue Doppler, this is little high-end echo assessment, and it global and segmental LV function can be assessed, early detection of LV dysfunction. Because now this entity definitely is a preventive aspect, we can act the moment we detect the onset of LV dysfunction, we can prevent and treat accordingly. The other function is dysynchrony. I was telling about the heart failure where the dysynchrony is there, because of that heart failure worsens. So the correction of dysynchrony after identifying makes a lot of difference for patients with heart failure. And 3D echo and intracardiac echo. Intracardiac echo, putting an electrode probe, a minute micro probe inside the cardiac chamber, can measure the lot of anatomical and functional evaluation and physiological functions also. The transesophageal echocardiography and 3D transesophageal echocardiography. This is the more proximity to heart, like an endoscopy up to cardiac site. So this gives a lot of information very clearly. And similarly, the advanced 3D, you can see the structures like a surgeon sees on the surgical table. From diagnosis to interventions, this TE, this ICE, that is intracardiac echocardiography, is essential for all structural heart interventions. Some interventions like mitral clip, the treatment for severe mitral regurgitation, the mitral clip, and this is a non-surgical, and LA appendage closure, exclusively TE dependent. The pediatric interventions like atrial septal defect closure, PDA closure, VSD closure device are essentially imaging guided only. The ICE I was mentioning, the intracardiac echo, helpful in electrophysiology procedures like ablation of ventricular and atrial arrhythmias. Transeptal puncture used in various procedures is better guided by imaging. The recognition of intra-procedural complications and vascular axis, ultrasound guided for large bore axis. Nowadays we do transcutaneous aortic valve replacements and transcutaneous mitral valve repairs or replacement and clips for severe valvular disease. We use the echocardiographic guidance basically for vascular axis, transfemoral, especially the large bore vessels. The next modality in imaging is the cardiac CT, and it is well known to everyone, and even without knowing people advise, without knowing people goes for this investigation. This is almost an alternative to invasive coronary angiography, but it has its own limitations. It evolved rapidly, very simple, and calcium scoring is more important here. We can get calcium scoring computerized counting. With high calcium score, the prediction for coronary artery disease, atherosclerotic disease and events are more. The next 1 decade we can predict the coronary events by knowing calcium score in the CT coronary angiography. This is an alternative to invasive, useful in assessment of bypass grafts. This is the important thing. Even before invasive coronary angiography, this gives lot of information for a cardiologist or cardiac surgeon by showing the graft's function and progression of native artery disease. This is cardiac CT is essential for structural interventions. TAVR protocol and actually the 3-Mensio software came into vogue for patients of severe aortic stenosis who are undergoing non-surgical procedures called TAVR. These dedicated protocols are there for mitral valve replacement also, and aortic aneurysms, dissections, the many cardiac problems like which can't be imagined by just echo or ECG or X-ray. And complications of post-procedure also, we have standby CT information. So here the same thing, like CT guided interventions of aortic and mitral. Even here, all what I told, transcutaneous valves replacement, here there is a outside the lab virtual assessment by CT angiography, by keeping the artificial valve virtually, can know any complications expected or anticipated during procedure, and the function of the virtual assessment can be known in advance before the procedure is done. So the next modality is the cardiac MRI. This is basically useful in assessing myocarditis and cardiomyopathies, assessment of myocardial viability, which is very important because unnecessary procedures can be avoided. Simple having triple vessel disease or multiple blocks need not be submitted for surgery or angioplasties. Because viability is not there, by MRI, we can simply manage the patient with medicines alone. Similarly, stress-induced ischemia, the myocardial function, and most importantly, the congenital heart disease defects, complex defects can be known clearly with congenital heart disease before sending him to surgery. And another important aspect of MRI utility is diagnosing a dangerous disease, hypertrophic cardiomyopathy, which is a genetic based and progressive disease, and many times by echocardiography we miss especially the apical hypertrophy and extreme hypertrophy. Even 20% of the time we miss, especially the hypertrophy in basal segments. So the MRI will pick up. Similarly, arrhythmogenic right ventricular cardiomyopathy, special entities where like very dangerous disease, It gives like arrhythmias, and the patient suddenly dies. Most of the sudden cardiac deaths are seen with this entity, and before that we can identify with MRI. Similarly, myocarditis. This entity we saw the patients land, but we could never diagnose in the earlier days. Now, especially this became more prominent post-COVID era or during COVID. During COVID, we have seen a lot of myocardial involvement, the COVID patients. People were dying with ventilator deficiency, dying with lung element, all those things. But the cardiologist knows, and we saw many patients with myocardial involvement, and MRI is the best answer. So whether it is because of COVID or something else, we used to differentiate and treat appropriately, timely. So this is another disease, separate disease, cardiac sarcoidosis. It is of late, it is more popularized. In the last 2 decades, we have lot of cases even from our own group, cardiology in Care Hospital, and the world record of case presentations also we did, a lot of patients. This is systemic, like involvement of many lymph nodes, lungs, and cardiac, heart. So this entity can be easily diagnosed now, even if suspicion, just suspicion itself, sent for MRI, we get the answer. Then I was telling about viability, which is very useful in preventing unnecessary procedures. So the next major, probably in the last important event is the interventional cardiology, from diagnostic to complex high-risk interventions and structural interventions. This is a man legend, fast man, who did first catheterization on himself, urinary catheter. He did catheterization through vein, left arm vein into the heart chamber. For this, the institute where he was working suspended him. They didn't allow him to continue. And later on, he got Nobel Prize in 1956. That is called consistency. We should never leave our work if we think that is right. So, along with some other people who developed catheters, etc. So, the cardiac catheterization then evolved into many, like first coronary angioplasty, then IVAS, is intravascular ultrasound, where we can see the intracoronary material, whatever thrombus or atherosclerotic process, and OCT, this is optical quiescence tomography. This is an advanced investigation tool where now present day we are left and right using from the 2018 onwards we are using, and plenty hundreds of high risk interventions can be done, and that gives approximately the stent position. Intervention is completely successful or not, and any future development of re-narrowing chances, all these things can be identified with the help of this modality, OCT. Then a lot of guidelines for the use. This is the man who was behind for present lot of interventions. Later on, wave of innovations like development of the complex interventions, and including carotid artery interventions, peripheral arterial interventions, and now the structural heart diseases called like LA, left atrial appendage occlusion, for preventing thromboembolic strokes, and the transcatheter mitral repair and transcatheter aortic valve replacement percutaneously. So there is an improvement in catheter design and development of lot of guideways, basically toolkit in cath lab. All these developments led to the lot of change in outcome of the patients. And similarly, stents development like drug-eluting stents and adjuvant devices like rot ablation, rotational ablation, and directional atherectomy, laser. The IVL is nothing but intravascular lithotripsy. When we were students, we learned only urology, that is kidney stones were treated with lithotripsy. Now the cardiac elements, especially the calcified coronary arteries, we are treating. Now plenty of cases even we did in our center, and it is ongoing developments like intracoronary imaging. I told the help, how they help, and coronary physiology, fractional flow reserve. The physiology of the coronary circulation is how significant we know before any like intervening. Majority of the interventions are sometimes unnecessary. So with this available information, we can avoid unnecessary interventions and manage medically. And the radial angioplasty, now the simplest procedure all over the world, and since it started, the mechanical circulatory support. These are the devices which helps in sick patients with cardiogenic shock and unstable patients like intra-aortic balloon pump and ECMO, Impella, etc. These are all available today. I was telling about the catheters development, different guide wires, different catheters. People are great, developed now to use, many of us struggling. But still, there is a lot of growth in that. The stent saga, the first stent in France was implanted in 1986, that is coronary wall stent. The same team, the first drug-coated stent also, that is Cypher stent, implanted in same center, France. These are all people whom really we all know, and even we worked with them. Today, they are the leaders of the world, conducting a lot of conferences in interventional conference in USA. So the still ongoing development is there in cardiac interventions, and evolution of stents, first generation. I think I can skip here. We know that next coming generation, people, youngsters may see, we may use shortly this bioreabsorbable drug-coated stents and cell-selective and personalized therapy. All these things are upcoming. The major advances development is stents, ultra-thin struts. The development in struts, each strut, the thickness depends, and the ultra-thin stents can be used for high-risk tortuous vessels and highly calcified blood vessels. So India is not lagging behind. Indian population are not lagging behind. Always people, till I don't know how long we call and accept this developing country. So lot of people going abroad, and they are the leaders and thing. But India is still remaining as a developing country. Even personally, I don't like in my lifetime. I think someday people should call developed country. See, the stents development, even in India, our group, with the great gentleman, Abdul Kalam, who helped us in technology from DRDO, we developed stent. Fortunately, I was associated for this work with our legends, our teacher, and is another legend from Guntur Medical College, Dr. none other than Somaraj. So fortunate that we all worked together and developed this stent, indigenous stent. I was associated with preclinical in goats in 1990s, and later on human trials. Then now it came into all over the world. they are using, and this stent made lot of reformation. The cost, the 1 lakh above stent came down to, this stent was 7,000 when we started using. So the government itself, thanks to whoever is Prime Minister, and controlled all the stent rates. Then we were proud enough that our stent made lot of changes in cost controlling, affordability. So all 3 generations we developed. Now it is widely used with low cost. And adjuvant devices, I was mentioning about rotablation and all those things. And this is intracoronary lithotripsy. I just mentioned about not only kidney stones, the cardiac vessel stones also can be lithotripsied. This is imaging, discussed many of the things. Hybrid intravascular imaging, I was discussing about individual thing. Now today, the last couple of years, started using 2-3 modalities which shows crystal clearly the anatomy inside what is happening after procedure. Vessel. See, this is seen outside in the monitor. That this was an angiography we thought successful, complete, like a good result. If you see the lot of thrombus, under expansion of the stent. So this immediately within 6 months, patient will end up with restenosis and cardiac events. So the hybrid intravascular imaging also one of the development. And next is radial intervention. Briefly, first done in 1989, transradial angioplasty was done in 1995, and now all over the world. And the very simple, safe, less complications. The patient is more comfortable on the table. From table itself, he will walk out. If after 1 hour, we can send home. You can sit. So the radial. So all these trials showed definitely the radial is better than femoral, where we used to struggle earlier between 90s, around 90s till 99 when we started using. So they showed the benefit, so there is undoubted. And this is landmark trials in coronary artery disease and evaluation of PCI, that is interventions, we mentioned already. And this is bypass surgery, similarly. And especially nowadays, we call off pump. The external cardiopulmonary bypass pump is not required. Without that, for high-risk patients, high like comorbid conditions, patients are not fit for really with pump. So surgeons are taking care of them. So here the one word, the left main. This is a very dead-end disease. The moment we see or we hear about left main disease, we used to run to the surgeon in 90s because there's no other option. Today, the interventions came. The surgeons used to claim as our disease, but the cardiologist definitely made a change, and most of the left mains now tackled by interventions, and lot of studies proved beyond doubt. This is CHIP, complex high-risk interventional procedures. This is the final frontier. I think you understood what I already mentioned about this thing. This is the present era, the talk about transcutaneous valve replacements. Now, this is the gentleman I mentioned, Crebier, who, this is the person, in France, the first to implant aortic valve percutaneously in France. Fortunately, I worked with him in 1996 for some weeks and saw his enthusiasm. That time he was trying to develop parallelly some valves, but he could succeed only recently, that is 2002 only. And recently, last year, he died. So this is TAVI, that is transcutaneous aortic valve replacement developments. It was indicated only in high-risk patients when it is started. Now it is recommended because the long-term follow-ups are available. So even younger generations also with some comorbid conditions, we are trying to do the procedures. The plethora of valves, you know, once development comes, the many things will automatically come into fall. Not only aortic, this is mitral, tricuspid, and pulmonary valves also can be tackled by percutaneous techniques. Same, like more than 50 valves are ready now for use. This is a little small, brief word about cardiac rhythm management. As I told, this is the pacemaker, external pacemaker for a patient complete heart block. If he wanted to go, he has to carry all this burden. So from there to miniature, like sizes came down, and intra pocket, like subclavian pocket, and very small, and later on. Now the present thing is, current developments are ongoing research. Cardiac myocyte itself will act as a pacemaker. That is for you, the younger generation. Research are going on. It is definitely, it will come out, and nothing to be done. The nanotechnology, Professor Jagadish field will transform the myocardial cell as a pacemaker, and nobody needs any external device or anything. So this is a special pacing, left bundle or his bundle. This helps in controlling heart failure and giving good quality of life, and this little cheaper than regular pacing. This is a defibrillator, intracardiac defibrillator. During our DM course, we used to read in the textbooks, and later on, fortunately, we got during our time only, the 96, first time I implanted in Nizam's Institute without any proctor in India. My teacher implanted in All Indian Institute of Medical Sciences with help from US cardiologist. So it is opportunity and good luck for me. I got opportunity to do all these procedures. So resynchronization, a word about it, like heart failure patients, dysynchrony documented in left ventricle, patients will be benefited by resynchronization. Resynchronization, this is leads, various leads, right ventricle, right atrium, and one lead in left ventricle in the coronary sinus. So in that, lot of developments and size of the device, all those coming into practical use. The word about ablation therapy, radio frequency ablation for arrhythmias. And from 1960, the first DC shock used to be direct current shock. The now developed pulsed shocks came, and radio frequency and cryoablation with cold, application of cold, -30, -40 degrees. So a lot of arrhythmias can be tackled simply with 0% mortality, very low risk. So this is basically the developmental era from 1960s to 2020. And the cardiac mapping, conventional to high definition. During ablations, we map under fluoroscopy. Now, the computerized 3-dimensional mapping, and accurately we know where the culprit, focus of arrhythmic production. So that area we selectively ablate, and success rate will be very high. Now, the few words about future cardiology. Future of cardiology, now with this last slides, I think everybody knows it is very bright. Very bright, I'm sure, more than what we are enjoying today, will enjoy much more simply, easily, and provide to the society. And this is basically invasive and preventive. Invasive, like 3D printing, I was telling about nanotechnology, tissue engineering, artificial intelligence. All these things definitely makes a lot of difference in future, and you people should take care of the youngsters. So preparing like the artificial heart, we can prepare artificial heart by with the available nanotechnology. And the size, initially it was a size, artificial heart, now they are becoming miniatures. And tissue engineering, how to build a heart. In fact, the heart is the simplest and the best organ can be made with tissue engineering. Out of all organs in the body, heart. Yes, the heart is, I've already mentioned, we'll do it in the decade. The scientist says in a decade time we'll get artificial hearts and no need for wait for somebody brain dead and transporting. And pacemakers I was mentioning, biological pacemakers, the same cardiac myocyte can act as a pacemaker. These are variables, and a patch itself can detect from a neonate all arrhythmias and treat accordingly on time. And lot of devices are coming, and digital takeover. So with technology, a lot of sensors, and this is the necklace in a patient. This detects all abnormalities of the cardiovascular things, and accordingly, even a remote, we can monitor and we can treat. Now, the word about nanomedicine. In fact, our Professor Jagadish, chief guest, is a pioneer and he is a world authority in nanotechnology. So I thought I will tell very briefly and then leave it to him only, or in future we can take his help. So the nanomedicine is nothing but it is a very small particles which can be used in diagnostic aspects and therapeutic aspects, and both theranostic, called diagnostic and therapeutic, and also helps in already implanted valves functional enhancement. What was existing will be enhanced with this nanotechnology future, so that the lifespan of the valves, lifespan of the individual can be prolonged. So here the other important aspect is not only diagnosing atherosclerosis, it gives signals, and by acquiring images by MRI and PET, it identifies the atherosclerosis in the coronary artery, and therapeutic, it clears the atherosclerosis by tagging the immunocytes, and so, and it delivers the drug also. The statins, so-called what we were talking earlier, the statins can be delivered. Now the already advanced and already more in use, the oncology side came, it selectively delivers and kills the cancer cell and spares normal cells so that no side effects. So a lot of things are there learning, and somebody can take up this in their future, the youngsters. Now the molecular to tissue engineering. Similarly same, I was mentioning, is all interconnected. Tissue engineering and developing the organs. This was I was mentioning. the cholesterol transport and can be halted and can be deposition can be halted and left the vessel free for flow. The last one is artificial intelligence, and the last one in my talk, but this is the starting for your generation. So concentrate on artificial intelligence and nanotechnology in your career, spend some time and learn. So the evolution we know, this is basically the artificial intelligence collects the data, lot of data, and helps in quicker diagnosis and even treatment decision wise. To some extent it helps, but ultimately the cardiologist, physician has to be there for decision making and right treatment delivery. So it is everywhere, not only just in medicine, diagnosis, and all other non-medical things also artificial intelligence used. So I don't know now, people may be having some ideas in future what happens if it develops. Maybe good definitely happens, but if it doesn't use properly, it harms also society. Hope for the future, strengths for the present, right? So I feel these are the two aspects, automatic diagnosis with the collected data and the precision medicine. These two aspects will be definitely developed with the available artificial intelligence technology. So what is the role of cardiologist then? All these developments automatically developed and getting used, but ultimately even robots. So ultimately this is the thing. The person final, once known all this information and everything, artificial intelligence quickens the diagnosis, but the implementation of correct treatment, the cardiologist has to be there. Yes, now the last two slides. The technology is supportive, not replacement. Every patient is different. The patient concerns and safety needs to be addressed, not just knowing technology and jumping. The medicine is probabilistic, not algorithmic. The experience alone helps in taking appropriate decision. So trust your own brain, trust your own ideas and your own experience. So the one cardiologist, multiple roles. This is clinical cardiologist, interventional cardiology, and imaging cardiology, and intensive cardiology, managing in intensive care. Robo cannot manage here. Artificial intelligence may diagnose, but managing. To conclude, growth of cardiovascular medicine has been exciting. There is a lot of scope is there. The last 4 decades have seen phenomenal growth in patient care and outcomes with this talk. Transformational changes from observation to interventional, and multiple treatment modalities available now. Future of cardiology seems promising, and digital health, nanotechnology, and artificial intelligence are bound to revolutionize healthcare in the world. But medicine is basically a clinical science. Don't forget the basic clinical science. Technology must be welcomed. Physician experience is central to take appropriate treatment and decisions. Clinical decision making must be strengthened. Here, the younger generation are very important for us, and they must be taught by the seniors and professors for growing, especially the clinical medicine. The patient concerns and safety need a human touch. Very important is human touch. Unless you have that, you develop that, all these technology goes waste, in my idea, in my opinion. Please maintain that human touch. Please give focus on human touch and then grow yourself and provide with human touch only. Thank you very much for listening. And sorry, I have to talk many things which are not. In fact, I have gone through your phase. I used to listen more number of talks which I never saw in books also. So I think this is not for teaching or anything, this lecture even for some non-medical people also. This is only for making people aware where are we now, what is going on in science and technology, especially in healthcare. So that is the only idea of my talk. I think I'm thankful to Professor Raja Garu, who gave me the opportunity to enter into Guntur Medical College, which was my dream. Now, anyway, I'm almost retired age, I can't enter as a faculty, but we never know what happens with, I think politician is not here, present political systems, we never know what happens and where I'll help or work. I would love to work till my end, love to teach, love to see youngsters grows for the society. Thank you all.
Now, hello. Now, Dr. Garu will take, the floor is open for any questions, any doubts. Some of you are studying first, second, third year. Some of you are in the nursing colleges. Some of you are in a different healthcare fields. Any doubt you have about heart-related intervention, any of the complications you have in your family, or anything, aspirin, Dr. Garu Jepparu, future is చిన్న హార్ట్స్ పెట్టబోతున్నారని, హార్ట్స్ని రీప్లేస్ చేయబోతున్నారని. అది కాకుండా మీకు ఎటువంటి డౌట్ ఉన్నా ఏదున్నా ప్లీజ్ డోంట్ హెజిటేట్. నో క్వశ్చన్ ఈజ్ యూస్లెస్. ఆల్ ద క్వశ్చన్స్ ఆర్ వెరీ వెరీ welcomed. The floor is open. Just raise your hand if you want to ask anyone any question. I am going to ask our famous doctor, interventional cardiologist, a simple question. You're all young people, right? Very young. And you think you are healthy. You think your hearts are perfect. You think nothing is going to happen. But so many people are dying in 20s, 30s, 40s. Why is it that Indian male and female, Dr. Garu, they're having so many complications, so young, and they're dying? Could you tell us simply and briefly what is happening to our arteries, what is happening to our lifestyle, please?
It's a very good question. I expected some of the students this question, but unfortunately they didn't ask. And as a senior citizen and well-read man, this question is not for him. This question is for the society, from the public who listens to my answer should follow. See, the topic, this aspect of getting into problems young age is basically there are risk factors. Now, especially in India, we find young coronaries, we call young coronaries. During my DM, this was one of my thesis topic, young coronaries, less than 40 years. Between 20 to 40 years, many of the people are getting heart attack, many of the people are suffering. So the reasons are, number one, the lifestyle. Number two, the risk factors. It comes in lifestyle only, like habits of smoking. In Indian population, we find younger generation, younger population are more smokers and getting into the trouble. The other is like stressful life, getting hypertension in early age and diabetes with stress, and the last but not the least is a genetic background which cannot be tackled now. The future, even the genetic therapy also is coming. We can control that. With all these things, people are getting into trouble. So, the answer or preventive steps are in this risk factors: quitting smoking and cool life, stress-free life. Telling is easy for me, but following, ambition now, promotions, work stress. Anyway, home stress I need not stress now, because nowadays that is more and more growing compared to our olden days. So all these things should be kept away, and whatever is possible to avoid in these risk factors should be avoided. If unavoidable hypertension or diabetes because of genetic basis, people should control properly, follow regular instructions from a physician or a family physician.
Thank you, Dr. Garu. 40 years ago, 40 సంవత్సరాల క్రితం, when I was a student in the university in Philadelphia, ఇదే ప్రశ్నని ఒక డాక్టర్ గారిని అడిగాను. ఆయన అమెరికాలో చాలా పెద్ద పేరున్న డాక్టర్ గారు. అప్పుడు ఈ డాక్టర్ గారు బహుశా ఏమో గిల్లాలు ఆడుకుంటున్నారు, మరి ఏమన్నా ఇంకా చిన్నగా ఉండుంటారు 40 సంవత్సరాల కిందట.
40 years ago, first year MBBS.
ఫస్ట్ ఇయర్ ఎంబీబీఎస్. మీ మాదిరిగానే నేను ఎంబీబీఎస్ కాదు, నేను డిడిటీ కాదు, ఏమీ కాదు. ఆయన ప్రశ్న అడిగాను, ఎందుకండి why are so many of the Indian young men and women are dying like this? What is going on? He answered exactly what మన డాక్టర్ గారు ఈరోజు చెప్పారు, కాకపోతే ఇంకొంచెం ఎక్కువ చెప్పారు. లైఫ్ స్టైల్స్ అని, మోడర్న్ లైఫ్ అని అప్పుడు ఉండేది కాదు. మీ మాదిరిగా జంక్ ఫుడ్స్ తినేవాళ్ళం కాదు. అయినా కానీ చెప్పారు, లెథర్జీ, నో ఎక్సర్సైజ్, బుక్ వర్మ్స్, సిట్టింగ్ అండ్ రీడింగ్. ఇండియన్స్ ఆర్ వెరీ ఫేమస్ ఫర్ ఇట్. అది చెప్పారు ఆ రోజు. ఆయన ఆ రోజుల్లో అల్ట్రా ఫాస్ట్ సిటీ స్కాన్ అని ఆయన వర్క్ చేసి డెవలప్ చేశారు. ఆయన పేరు డాక్టర్ డానియల్ రైడర్. ఇప్పుడు బతికున్నారో లేదో తెలియదు, కానీ దాని తర్వాత మిగతా స్కానింగ్స్ అవన్నీ వచ్చినాయి. ఒరిజినల్ అల్ట్రా ఫాస్ట్ సిటీ స్కాన్ని డెవలప్ చేసి మన ఆర్టరీల్స్లో కాల్షియము అవి క్యాల్కులేషన్స్ చేసేవాళ్ళు. నాకు బాగా గుర్తుంది. ఐ వాజ్ హిజ్ గినిపిగ్. గినిపిగ్ అంటే ఎక్స్పెరిమెంట్. నన్ను పెట్టారు, ఫ్యామిలీ హిస్టరీ ఉంది కాబట్టి. సో డాక్టర్ గారు ఏం చెప్పారో ప్రివెంటివ్గా, you all have to follow very, very, very specially. Your young boys, young girls, and so much is going on outside. You eat anything that comes, you eat on the street. No, you must be very disciplined, and you must choose what you want to eat and what you do not want to eat. So thank you, doctor. The follow-up question for you is, they say you should take as a preventive measure baby aspirin. Baby aspirin is 81 mg. Is that really necessary for us to take? Because there are some risk factors. With the baby aspirin, we can have bleeding. Some people say you take it for preventive for your problems. Some people say don't. Risk versus a reward. Should people who have risks, should they continue to take baby aspirin, doctor?
It's a very good question, because basically a lot of people talk differently about aspirin. And very importantly, this baby aspirin definitely prevents thrombosis and improves coronary circulation. But who has to take this? as a preventive measures. These preventive measures are called primary prevention and secondary prevention. Primary prevention is like without having any disease, with some risk factors like a smoker or some diabetes or history, family history, like father or mother suffering from coronary artery disease. At what age they should start? Especially we recommend after 40 years of male, after 50 years of female, because premenopausal protects female. So they don't require that much protection without risk factors. Suppose even a premenopausal woman having risk factors like diabetes, hypertension, we suggest them as on par with men above 40. That is primary prevention. With occurrence of disease like some angina, some infarction, already whatever age, 25, 30, the secondary prevention, the aspirin is must. And as you rightly said, the complications. So carefully we monitor like any acid peptic disease, ulcer disease, bleeding, piles are bleeding somewhere, eye bleeding some people. So closely monitor and then continue forever, lifetime.
Thank you, Doctor. మీరు ఇంటర్వెన్షనల్ కార్డియాలజిస్ట్ అని చెప్తారు. మాకు కార్డియాలజిస్ట్కి ఇంటర్వెన్షనల్ కార్డియాలజిస్ట్కి భేదం తెలియదు. మాకేమైనా నొప్పి వస్తే కార్డియాలజిస్ట్ దగ్గరికి వెళ్తాము. దానికి మీరు ఉన్న స్పెషల్ ప్రొఫెషన్కి కొంచెం భేద కానీ తేడా కానీ మాకు చెప్తారా? మీ దగ్గరికి ఎప్పుడు రావాలి, వాళ్ళ దగ్గరికి ఎప్పుడు పోవాలి?
Just repeat, sorry sir.
డాక్టర్ గారు డిస్ట్రాక్ట్ అయ్యారు, అందుకని మరలా చెప్తాను. వాట్ ఈస్ ద డిఫరెన్స్ బిట్వీన్ అ కార్డియాలజిస్ట్ అండ్ అన్ ఇంటర్వెన్షనల్ cardiologist that you are?
See, one thing, the cardiologist is comprehensive cardiologist. Basically, if you mention interventional cardiologist word, that means this cardiologist, whatever you mentioned cardiologist, is a non-interventional cardiologist, non-invasive cardiologist. So he practices only clinical medicine. So without getting into interventional procedures. So for me, all cardiologists should be like comprehensive. When required, they should be doing interventional procedures. So exclusively present day, what happens is like the Europe and US, your US. Already we mentioned sub-branches, sub-branches in cardiology. So there they select, suppose they select only electrophysiology. They don't even see a patient. They don't even bother about heart attack. Even if he's dying in front of, because I saw, personally I experienced in US how they get involved into it. Because they're all, people are there, adequate people, and so these are all subspecial cardiologists. The interventional cardiologist, he spends his whole life in cath lab, like an anesthetist. So the interventional cardiologist gets involved in all interventional procedures, that is called invasive procedures, like tackling walls, tackling blocks, tackling holes, birth defects by closing with devices.
చక్కగా చెప్పారు. ఇక్కడ ఎందుకు why they use the interventional cardiologist అని నేను చదువుకున్నాను. నేను డాక్టర్ని కాదు, కానీ రోజు చదువుకుంటూనే ఉంటాను. ఇంటర్వెన్షన్కి ఇంటర్ఫియర్కి తేడా ఉంది. ఇంటర్ఫియర్ అంటే ఏమంటారు, ఎవరైనా చెప్పగలుగుతారా? ఇంటర్ఫియర్ చేశారు నేను మాట్లాడేటప్పుడు అంటే ఏంటి? కానీ ఇంటర్వెన్షన్ అంటే నేను మాట్లాడే దాంట్లో కొంచెం బాగా మాట్లాడండి, అది ఇది. ఇంటర్ఫియర్ అంటే నన్ను ఆపేయటం అనమాట. సో కార్డియాలజిస్ట్స్ ఆర్ ఇంటర్వెన్షనల్. Sometimes regular cardiologists may be doing, some other problems may occur, but doctor can come and intervene and save the patient. That's what I understand. ఫైనల్గా ఒకటే ప్రశ్న అడుగుతాను, ఎందుకంటే నేను అడుగుతూ ఉంటే మీరు ఇక్కడ ఉంటారు, భోజనాలు కూడా చేయరు. డాక్టర్, this is what is happening around the world. The biggest problem we have in healthcare are the number of people who die, mostly because of the cardiovascular complications and so on. Many people say it is not always necessary to have stents put in when there are blocks. It is stent, it is not stunt. Gurtupettukondi. Why do you, why people say, oh, they put in a stent for me, oh, it was not necessary. So could you tell us briefly, are the stents being misused, overused, or not used? And the medicated stents and the non-medicated stents, I understand there is no non-medicated stents. So basically, if you tell us, so if I have some problem that I know whether I must have a stent or not ani, ఈ స్టెంట్స్ గురించి మీకు మాకు బ్రీఫ్గా చెప్పండి. థ్యాంక్ యూ.
So the question is stents, misuse and abuse. So this is partly correct in the society, medical field. Unfortunately, I have to talk on this very clearly. See, I was mentioning during my talk, to avoid interventions, to avoid surgery, we have diagnostic modalities. All patients with blocks doesn't require interventions. That is 100% right statement. All patients doesn't require. So, categorically, the good clinician, that's why I was mentioning, don't forget about foundation, clinical medicine, clinical science. The good clinician decides whether this patient requires stent or not. So we all, interventional cardiologists, should know, should go back to clinical medicine and take the help of the developmental imagology, which helps in detecting really this patient is having multiple blocks, whether he requires or not. But unfortunately, all the modalities are not available. But sometimes what happens is the borderline zone, the indication was borderline zone. The patient repeatedly comes and these investigations are not there whether to do or not. So the cardiologist decides for the procedure. So it may be genuinely indicated or may not be. So some people, I'm boldly telling here, some people are there. They don't think anything. Some, they make indication and they do the procedures. And patient also is happy. He is not blaming just cardiology population, blaming public also. I'm telling you because I'm practicing last 45 years. I know patients, how they behave. For your point, your answer, some of the reason is this. Comes from some area, district. Somebody tells, you need stent. Comes to me. I say, no, you don't require, with the evidence of whatever knowledge, material. So he will not be happy. So 10 to 15% of population are there. He'll go to somebody and he'll tell there. Somebody told me already stent, I prepared with money, everything, and Surya Prakash refused to do procedure. Then easy for the person, present day population, you know. So that type of people, 10 to 15% of the people are getting stents unnecessarily because of various reasons. The culprit patient, culprit cardiologist is the reason. That is another thing, the previous interference and I'll just, interference is a very important word. Interference is not a nuisance, it is mandatory when it is needed. I'll tell you, the good cardiologist, intervention cardiologist, does procedures very well, right? The best cardiologist interferes when to be done or when to be not done. So the interference is mandatory for in all fields with all human beings, respect to the interference word. Timely interfering saves many lives, saves many social lives.
చక్కగా చెప్పారు. యాజ్ ఫార్ యాజ్ ఐఎమ్ కన్సర్న్, మీరు నన్ను ఇంటర్ఫియర్ చేయొద్దు. డాక్టర్ గారు చెప్పినట్లు చివరిగా డాక్టర్ గారు, ఐఎమ్ సారీ, నేను తెలుగులో మాట్లాడుతున్నాను, అనుకోబాకండి.
నేను కూడా తెలుగులో ఆన్సర్ చేస్తాను.
There are medical students, first year, second year, some of the students, some of the nursing college students some students have come from Loyola Public School who want to be budding doctors some point. మీరు ఈ ఫస్ట్ ఇయరు సెకండ్ ఇయరు ఈ స్టూడెంట్స్కి, బిగినర్స్కి మీరు ఒక మంచి మీ అనుభవంతో ఒక అడ్వైస్ ఇవ్వండి. వాళ్ళు మిమ్మల్ని గుర్తుపెట్టుకుంటారు ఫస్ట్ ఇయర్ సెకండ్ ఇయర్ తర్వాత ఏమవుతుందని. క్లుప్తంగా వీళ్ళకి మీ అనుభవంతో, వీళ్ళు కొత్తగా చేరారు కాబట్టి బుక్ వామ్స్ కాకుండా ఇంకా ఏమి ముందు చదువుకోవాలనో పైకి వెళ్ళాలనో మీ మాటల్లో చెప్పండి.
ఇంగ్లీషు, తెలుగు. See, it's very important. In fact, we don't have much time, so I would like to talk to more undergraduates, more youngsters in this aspect. See, you're all cream of the society. You should remember how you reached this stage, MBBS. Competition, the lot of competition. Lakhs of people appeared for NEET exam and you people got into. So don't underestimate yourself and don't overestimate that you are so great and forget about your responsibility of learning, practicing. And listen to all teachers. See, all teachers may not be thorough gentlemen, thorough like knowledgeable. We all faced this. We used to we didn't know initially, we used to avoid classes from some lectures. That was not correct. Luckily somebody corrected us. So after all, teacher, he read before coming to you and he is trying to teach, taught many things and which you don't know. So if something is boring, like my lecture today, you take some of only few things from the teacher. So you have lucky to have many teachers. So 10% of the good qualities of each teacher, if you take, you are the king. The vast knowledge, vast subject you will get. That is one aspect I wanted to tell. And another thing is, just remember, maybe most of the people, why they came to MBBS, I think they know. Maybe, I think with the age like now, maybe reasons are not too good. But don't forget that our profession is a noble profession. No other profession can be compared with our profession. So many of the people depend on our behavior, our activity, our touch, human touch. So that everyone, all students should think about that. So we are special, we are different, we are in noble profession. So how best we can be utilized in the society. That is one. The other thing is, in the interest of people may develop interest in administration, in neurology, cardiology, whatever it is, or surgical skills. people have opportunities. Everybody has opportunity. Out of 150 MBBS students, all 150 got opportunity to have all classes, all teachers, all facilities in the medical college. So why only some people are getting into central institutes, going into abroad for higher centers? That itself shows the interest or dynamism or commitment or hard work. So I think these few points may be helpful to you, and the commitment and should not leave in between. Learning and using things and utilize the opportunities. And at the end of MBBS, we know everything will be blank. Internship. During internship, I think nowadays people are not taking serious about internship work, because I'm seeing the last 40 years, that is the most important period, that 1 year period. Forget about NEET, automatically subject will come. For NEET preparation, PG entrance preparation, people are neglecting internship. Till MBBS final year, just students only, we never ever work hard for patient care, right? The only patient care starts during internship. You have independency, lot of opportunities in different postings. So work hard during internship. You will learn practical points which are definitely useful in your PG NEET exam. I'm 100% giving, because I'm our group, our batch also, I've seen the test. So never think that house agency is a waste. You go prepare for USMLE, all those things are secondary. That 12 months period you will never get in your lifetime. The 12 months period. Like thanks to whatever it is, like people who suffered, professionals during COVID period. I don't know how many of interns worked during COVID period. Genuinely, the vast experience. Even I learned during COVID, the myocarditis I showed. Enormous population, like the more than 30% of cardiac involvement with myocarditis. I have seen, I have dealt uncontrolled arrhythmias. Lucky to have knowledge in All India Institute of Medical Sciences with my teachers. So the 12 months period, I think this I concentrate here, I stress this 12 months house agency. You people tell, including your juniors, first year, second year, third year, by the time you reach internship, deal it separately. And 1 year in medicine, whatever, even if you don't get PG after NEET, don't worry. Even we all wasted. Even I didn't get immediately, I didn't want to join in Andhra Pradesh. So I have to wait for a 1 year for getting into All India Institute of Medical Sciences. And later on for DM also I wasted, not wasted. I got enormous experience in emergency medicine in AIMS before getting into DM. So utilize. Don't think that if you don't get PG seat in immediately after house agency, that is not. I feel if you don't get, you are lucky. Because you got time to work hard, time to get exposure, to mature yourself and tackle the next need, and you will be the number one in your batch with this 1 year exposure. So అది ఒకటి. తర్వాత another thing, important thing ఏంటంటే service. After all, today undergraduates, tomorrow postgraduates, then what? Plan yourself right now. What type of service will provide to the society? And lot of big opportunity is there. India is still developing country, as I told in my talk, still developing country. Lot of people need our help. Just 10% of your time, 10% of your time, 10% of your earnings, devote for the human service as a noble professional group.
Thank you, Dr. Garu. Doctor has given us an overview of first, second, third, fourth, and then later on what happens. And such a valuable advice you cannot get from anyone around here. And there is a question coming up from there. Could you ask loud?
Mic పంపండి లేకపోతే మైక్ ఇచ్చేయండి.
Rama, పరిగెత్తుకుంటురా. Jump over. Well, finally, your representative is going to be asking a question. Give her a clap.
Sir, this may be a bit distracting.
Introduce yourself.
This is Trinaini, sir, and I am studying MBBS first year in this college. This may be a bit distracting from your medical profession, sir, but you say doctor is a noble profession, but you say people need human touch. But the same people say that AI can replace doctors now. So what's your opinion about that?
This is never-ending problem, is ongoing. See, we can't change total human population in the society. So we should try, we should take help from people who controls human beings, and we should go on. We should never end or stop our activities with human touch. Just because somebody is inhuman, we can't be inhuman. So we react. There is no doubt, as a human being we react, but there is a limit. As a noble professional colleagues, we less react and more do the job. So I don't think there is a 100% answer, definite answer for that. We have to keep going and do our job with best efforts.
Thank you. Thank you, doctor. Thank you, young lady. So let us thank this wonderful doctor who came all the way driving 6 hours yesterday only to be here, and he presented 100 slides. Some of you may not have understood completely, but those 100 slides give you the history of cardiology, the evolution, and the observational part of what is going on in cardiology. And this particular lecture oration series is dedicated to Dr. Nirmala Karnam. ఆవిడ ఎక్కడున్నా కానీ తను ఇక్కడనే తిరుగుతూ ఉంటుంది. అప్పుడు ఈ ఆడిటోరియం లేదు, జిమ్కానా, కానీ థింకింగ్ స్టాచ్యూ ఉంది, అక్కడ ఆ ఏరియాలోనే తిరుగుతూ ఉంది. సో డాక్టర్ సూర్య ప్రకాష్ గారు, we cannot thank you enough. We have no words to express our thankful gratitude. It is a journey of love. It's a journey of dedication to be here today to address all of you wonderful, beautiful, handsome looking young students. And Dr. Garu comes many times to Guntur every month throughout the year. Particularly when I had requested, he said, okay, I'm coming. 25th was supposed to be the day last month this oration was supposed to take place. Because of your inspections, it was postponed for today. And doctor had to redo. He goes out at 7 o'clock, comes back at 11 o'clock. What kind of life is that? And I hope your life will be better than that, because he's so much in demand. So many people he saves. Thank you, doctor, for being a lecturer, orator, and the Immaculata Foundation is extremely grateful to you, thankful to you. We are honored, the foundation is honored, Nirmala is honored, all of us are honored. May I have Madam Dr. Rajeshri. She is not just a doctor. She is the doctor who studied here, who walked here, who taught here microbiology. She will be honoring our chief lecturer today.
Thank you.
And how honored we are to have Dr. Rajeshri, an MD microbiologist, a teacher and professor who has come ahead of time, sat here patiently, listened. She listened every word of it, and I could watch her. So we are going to honor her, and doctor has already honored.
Right. Thank you.
And we have in the middle of here, Dr. Gautami from Narsaraopet. She is a gynecologist. She is a gold medalist. Mostly you have a gold medalist of your class, of your college, of your state. But have you seen a gold medalist of the country in gynecology? That's what she is. We are honored to have her to come all the way from Narsaraopet, even though she's not that well, to come here to attend the lecture, honor you, honor Immaculata Foundation. May I request Dr. Rajeshri Garu to honor her, and also ఒక మంచి సాల్వ్ అని కూడా కప్పమని అడుగుతున్నాను. ఈరోజు ఇక్కడ జరిగిన ఈ కార్యక్రమం, దిస్ పర్టిక్యులర్ సెగ్మెంట్ ఈజ్ a multiple part of what happens in life. People are honored because you are honored. So it is because of you Immaculata Foundation could conduct this particular lecture series. To start with, I take this opportunity to thank your young and good-looking principal for giving me this opportunity, and also Dr. Reddy Garu, who started it so that we could be here. So my grateful thanks to both the principals, and let's give them a hand. I thank both of your vice principals who stood behind me and got me here, and I thank both of them. I thank the principal of Government Nursing College for sending their nurses, contingent of them, even though they were busy. The principal and the vice principal of Government Nursing College, I am very grateful to them for sending their contingent here so that they will be benefited from what is going on here. And let's give it applause for the principal and vice principal of Government Medical College. I especially thank, in a way, the principal of Loyola Public School, Father Suresh, for sending another contingent so that they could benefit. And I thank you, the wonderful young boys and girls from coming to Loyola Public School for gracing this occasion. Thank you, Father Suresh. I thank one, I especially want to thank a humble doctor here who came all the way from Hyderabad. 24 years she was in practice of diabetes and obesity. And as I said, she is a beauty of the state, of the country, of the universe, Dr. Shobha Devi. And we have to honor her. She has refused to come onto the stage, and she has to come to the stage till, you have to clap till she comes here. Dr. Shobha Devi Garu, you have been here earlier. She conducted a diabetes camp in our village in Katrapadu, and then in the nursing college, and then Loyola Public School. She saw almost 1,000 people and put her head down and continued for hours and hours and hours to know what is happening to the young people, middle-aged, and the older generation. And that is service. And on top of that, yesterday she traveled with our lecturer, orator family, and then came last night to be with you. And that shows dedication. She does many camps. She attends many lectures. Thank you, madam, for coming here. We are very honored to have you here this morning. And I cannot say much about Dr. Rajeshri, Dr. Garu, microbiologist. Ikkada puttaru, ikkadne chadukunaru, ikkadne teach chesaru, marla ikkada mana daggaraku vacharu, rozanta ikkada కూర్చున్నారు. I am very, very grateful to you, madam, for being here. And may the madam be honored with a bouquet. And there are many people behind what happened today. We had the principals, vice principals, chief guests, and everyone. Let me start with the non-teaching staff. Helped us in having this go perfectly, without a hitch. And I thank the entire non-teaching staff who helped us. And I also thank all the professors, heads of the department, chief of the cardiologist who spent most of his time here for coming here. I thank especially the MLA, the young lady. Vigrahamu chinnade gaani avada keerti chala goppadi. Let's give her a clap for coming. I thank Madam Ruxana, who is the manager of GMCANA, and she is ubiquitous. She is there everywhere, and she made it possible for everything that is going on here. She and her husband Ramesh and her crew, they put together a wonderful show for us, audio, visual, and other things behind. So let us give a clap to Ramesh Ruxana Madam, and to the crew. And I thank Father Velangani, who sent his wonderful cameras and camera technicians who telecast this particular series session around the world. By morning, hundreds of people in US, UK, in other countries have literally watched what went on here. They're not just the Indian doctors, they're all many American doctors, many other countries' doctors. So we thank the crew that telecast this series, and thank you for being wonderful videographers and for taking this program to the rest of the world. And it may not be last, but it is important for me, especially, to thank my brother who had come all the way from US to be here with me, and my sister, who is a retired professor from Karnam, who is in the background, feeding me, taking care of me, advising me, agreeing to disagree with me, disagreeing to agree with me, and her friend, Fatima Madam, and all the people who worked so that I could be in front of you. I thank them, and please give them an applause to my immediate family. And there is another very, very important person here sitting. He is a very leading lawyer, our brother-in-law, and his name is Lawyer Balarazu. He practices not too far from here. If you have a problem, you can go to him. He can influence the judge and get you winning. So, I would like to acknowledge, if you could stand up, Dr. Balarazu and his lovely wife. May I have Sujata also get up, and his son Bablu and the crew. They did a lot of work in every aspect of this. Nothing was ever compromised. And I do not know who else that I may have missed. I have no idea. And if I have missed, please hit me with a hammer on my head. I got very tough head. So, and so when you come to the end of it, when you have so many people, did I miss anyone, Lawyer Garu? Lawyer Garu, did I miss anyone? Andarni gurinchi cheppana? Okay, but you do not know one person I missed. అందుకనే మిమ్మల్ని అడిగాను. ఎవరో తెలుసా? ఎవరు? నేను కాదు. డాక్టర్ కోదండ రామయ్య చెన్నుపాటి. మీరు కోదండ రామయ్య గారిని ఆనర్ చేయండి. మేడం. And he was the right hand of Abdul Kalam Garu. Do you know who he is? He got his PhD from London in physics. కోదండ రామయ్య గారు మా ఊరు కట్రపాడు, పెదనందిపాడు పక్కన. కోదండ రామయ్య గారు ఎన్నెన్నో పొజిషన్స్లో ఉన్నారు. లాస్ట్ పొజిషన్ he retired as Dean of Pondicherry Long Distance University. And not that alone. Every bit of program that is done, mostly all compositions, as well as all the 100 slides that were projected, he was behind it. And he was my oxygen so that I could breathe while I was doing. So thank you, Kodandrame Garu. And well, ladies, you have to see this. Lakshmi garu unnaru akkada venaka, ayana Satimani garu, cheyattandi, munduku randi. Avid garu ayana venaka lepothe idi jarigedi kaadu. She is the silent, serving, obedient, commanding wife. I have emceed several places in several under conditions that I cannot explain. But I have seen here Chinna Chinna Saraswati Matalu. Kottandi. అదే కాదు, ఇక్కడ సరస్వతి మాతలే కాకుండా కొంతమంది చక్కటి అందమైన అర్జునులు కూడా ఉన్నారు. See that? So, Nirmala madam, మీరందరూ ఎవరు పుట్టలేదులేండి, డాక్టర్ గారు కూడా చాలామంది పుట్టి ఉండరు ఇక్కడ. ఆవిడ ఎక్కడున్నా కానీ మీ మంచి కోరుకుంటుంది. ఈ క్యాంపస్లోనే తిరుగుతూ ఉంటారు. మీరు ఎప్పుడన్నా పడ్డా ఆవిడ లేపుతారు. ఆ థింకర్ స్టాచ్యూ ఉంది చూడండి, ఎప్పుడు తను చూసే తనకి ఇన్స్పిరేషన్ వచ్చిందని నాకు చెప్పేవాళ్ళు తను. సో ఆ థింకర్ స్టాచ్యూ గురించి మీరు చదవండి. ఒకరిని నేను మర్చిపోయాను, నా ఫ్రెండ్స్, నాతోటి వచ్చిన వాళ్ళు, చిన్న చిన్న ఊళ్ళ నుంచి వచ్చిన వాళ్ళు, ఇక్కడ ఉన్న వనితలు, నా క్లాస్మేట్స్ కొంతమంది వచ్చారు. తర్వాత బయట నుంచి ఆహ్వానించిన వాళ్ళు వెంటనే ఇక్కడికి వచ్చి మనల్ని గౌరవించి మనకి దే హ్యాడ్ గివెన్ అస్ సంథింగ్ that I have never gotten wherever I went. So I thank every friend of mine, every classmate of mine, everyone who came here, who stood with us. Well, I am not asking anything from you other than I am asking from you forbearance for being your MC, and I am very proud, and I hope I did my job with respect, with honor, with love, with dedication. థ్యాంక్ యూ. రెండు మాటలు మీకు చెప్తాను. మోస్ట్ ఇంపార్టెంట్ థింగ్ ఇన్ యువర్ లైఫ్ ఈజ్ కమ్యూనికేషన్. కమ్యూనికేషన్ కమ్యూనికేషన్. మీరు చూశారు కదా, నేను మాట్లాడితే లాస్ట్ సిలబుల్ కూడా మీకు వినపడింది కదా, తెలుగులో కానీ ఇంగ్లీష్లో కానీ. బీ కమ్యూనికేటర్స్. When you go out into the world, your knowledge is much, much smaller than how you can communicate. So, good communication, and learn to speak, learn to read. That's all I can tell you. And now, please be seated. Dr. Rajeshri Garu, 1-2 words మీకు చెప్తారు. దాని తర్వాత
I'll be failing in my duty if I don't appreciate and thank Raja Garu for all the efforts he has taken in respect of his wife Nirmala Garu. Just that is what I exactly wanted to say. Vote of thanks to Raja Garu, and Jagdish Garu has taken that turn. I thank you. And another thing, that little girl, Amma cheppavu noble profession annaru ani. Definitely it is a noble profession, no doubt about it. Vidya Vaidya rendu noble professions. Na adrushtam koddi rendu naaku dakkinayi. వైద్య విద్య రెండు కూడా నాకు దక్కటం అనేది నా అదృష్టం. అలాగే మీ అందరిలో కూడా చాలామంది అటువంటి అదృష్టాన్ని అందుకోవాలని కోరుకుంటున్నాను. కాకపోతే సమాజంలో ఉన్నటువంటి పరిస్థితులకి మనం దిగజారిపోయి మనం దిగులు పడిపోయి ఉండటం కాదు, వాటిని ఎదుర్కోవడానికి శక్తి తెచ్చుకోవాలి. మనం వాటిని ఎదుర్కొని ఇంకొకళ్ళు అలాంటి వాళ్ళు పైశాచికంగా సమాజంలో రాకుండా ఉండేటట్టుగా మీ జనరేషన్ అంతా తయారవ్వాలి. దట్ ఈస్ మై advice, humble advice to all of you. I wish all of you all the best, and you should come up in good colors. Nirmala gariki హృదయపూర్వకంగా ట్రిబ్యూట్స్ తెలుపుకుంటున్నాను. నాకు ప్రిన్సిపల్ గారు అన్నట్టు త్వరలో ఆమె కూడా మీలో ఒకళ్ళుగా వచ్చి కూర్చోవాలని కోరుకుంటున్నాను. మళ్ళీ
ఎంత చక్కగా చెప్పారో. వెరీ వెరీ వండర్ఫుల్ వర్డ్స్. అండ్ నౌ అవర్ చీఫ్ గెస్ట్, the world famous జగదీష్ గారు 12ంటికి వెళ్ళిపోతామని నాకు చెప్పారు. ఆయన ఎంత బిజీయో ఈ ప్రపంచంలో చెప్పలేము. కానీ అనుకోకుండా ఒక దేవుడు దిగొచ్చినట్లు మరలా మనం ముందుకు వచ్చేసారు. ఇది మీ ప్రేమతోటే వచ్చేసారు. తనకి ఇంకా అయిపోయిందండి. ఆఖరిలో లాయర్ గారు మిస్సెస్ దీన్ని వెనుకున్నారు కాబట్టి వారికి కూడా కొంచెము గౌరవం ఇద్దాము. దాన్ని తర్వాత మనము చేద్దాము. మా దగ్గర కొన్ని నిర్మల కర్ణం గారికి పబ్లిష్ చేసిన బుక్స్ ఉన్నాయి. కొంతమందికే ఇవ్వగలుగుతాము. సినిమా టికెట్ మాదిరిగా ఎవరైతే ఎగబడి తీసుకుంటారో వాళ్ళకే వస్తుంది ఆ పుస్తకాలు. కొన్ని బుక్స్ ఉన్నాయి, కొంతవరకు ఇస్తాము. లేని వాళ్ళకి నేను మీ వెబ్సైట్లో ప్రిన్సిపల్ గారు బుక్ పెడతామన్నారు. మీకు కూడా అమ్మా అందరికీ మీరు చదువుకోవచ్చు. ఇక్కడ ఉన్న బుక్స్ని మరి ఏ విధంగా ఇస్తామో తెలియదు, లేకపోతే క్లాస్కు 2-3 ఏదో విధంగా తీసుకొని వెళ్ళండి. అండ్ దెన్ ఐ హ్యావ్ అరేంజ్డ్ some sweet and hot snack, and then a bottle of water. Kindly take it. It's a humble gift from Immaculata Foundation. Once again, thank you. This is the beginning of the end of all ignorance. We start knowledge. We start sharing the knowledge. The power of sharing the knowledge is the future of this world. When we went to school, పంతులు గారు పాఠం చెప్తే ఆ నోట్స్ తీసుకొని షేర్ చేసేవాళ్ళం కాదు. But you need to share whatever you know. In sharing, you succeed. We see our chief guest is a world famous. And he has come here and he has honored us, but we are going to get the best out of him somehow. The country has to get, the state has to get. Incredible things are happening. So long, have a wonderful life. Vanitha Foundation will not forget you. It'll come every year, and my personal thoughts, wherever I am, even those people who are talking behind, I still love you, and I'll follow you. I'll pray for you. May you succeed. May you become wonderful students. May you graduate. May you become with good health, safety, a long life, you and your families. Thank you for coming here. Thank you again. సాడ్ థింగ్ ఏంటంటే నాకెవరు కప్పలేదు, నాకెవరు పువ్వులు ఇవ్వలేదు. ఎందుకంటే మీరు నేను ఒకటే, మనం కప్పుతాం కానీ కప్పించుకునే వాళ్ళం కావు. చాలా లేట్ అయింది. మీరందరూ ఏదో కొంచెం తీసుకొని మీరు బాగుండండి. And I love you all. Thank you. ఇంత ఆనర్ నాకు అంత గొప్ప మనిషి దగ్గర నుంచి వచ్చిందంటే, రేపు నేను అమెరికా వెళ్ళిన తర్వాత డిసెంబర్లో ఐఎమ్ టెన్నిస్ ప్లేయర్. ఐ ప్లే 6 to 8 hours టెన్నిస్. ఫస్ట్ టెన్నిస్ గేమ్ ఆడినప్పుడు దాన్ని డాక్టర్ చెన్నుపాటి జగదీష్ గారికి మీ అందరికీ డెడికేట్ చేసి గెలుస్తాను. థ్యాంక్ యూ.